Right tool for each task. AI certificate.
Good morning, everyone. Am I audible? Can you please put it into your chat box? Yes, thank you. Thank you very much. So, I welcome you all to our webinar and a CME on Obesity 360. There are many topics, and as you all know that it is a very, very, very discussive matter of obesity, and it has now been recognized as a disease itself in metabolic disorders. And for this, we thought that we should come up with a very beautiful agenda, and we have a physician, cardiologists, pharmacologists, diabetologists, surgeons, all involved in giving academic feast on Obesity 360. So, for a welcome note, I call upon Dr. Muhammad Shafi, sir, Director of Elite Education and Welfare Society, to kindly give a welcome note. Very good morning to all of you. I welcome all the delegates who have registered for offline and online CME. This is our 12th CME since we have started CME program in 2023. In that, we have conducted 5 offline and 7 online CMEs. So I welcome you all, the delegates who have registered for this CME, who are attending offline and also online. I can see almost more than 50 delegates have joined online for this CME. This is our second CME on obesity. Before this, we have conducted one more CME regarding obesity. Obesity is very common problem and increasing day by day. So, on behalf of Elite Education and Welfare Society, I welcome you all to this CME. I am very thankful to our chairman of our college, JIIU's IMSR, our beloved Dean Dr. Azhar Siddiqui, for allowing us to conduct these CMEs on college name and supporting always us to conduct such academic activities. I'm very thankful to all the speakers. Just by message or WhatsApp, they agreed to be speaker for today's CME. I'm very thankful to them. And once again, I welcome you all and we'll start the CME now. And I request all the delegates who have joined online, please stay. Time to time, we are going to take the screenshot and attendance for this CME. So once again, I welcome and I ask Dr. Zubair to continue. Thank you. Thank you very much, sir. So, I'll make an announcement here that after our first talk with Dr. Nilofar Patel, I will be taking the attendance and I'll request you all to open your video cameras at that time. I request all the delegates to kindly keep their mics off, though we have done the setting, but when you rejoin, so the mics get on, so you please immediately switch off your mics. And for any query you are having, you can communicate on the WhatsApp group so that we will handle it accordingly. So for our first talk, I call upon Dr. Nilofar Patel. Dr. Nilofar Patel is an MBBS MD doctor. She has done a distant fellowship in diabetes from CMC Vellore, currently working as assistant professor in Department of Medicine at MGM Medical College, Chhatrapati Sambhajinagar. She is consultant at Naira Hospital and Diabetes Care Center and currently pursuing the highest degree of PhD in general
internal medicine in MGM. And she believes to be committed to excellence in patient care, medical education, research, and diabetes care. So I share your screen, ma'am, and invite you to kindly.
Audible? Good morning, everyone. Myself, Dr. Neelofar Patel, and I'm going to cover the topic that is clinical evaluation of obesity, what every doctor must know, a practical approach and diagnosis to obesity. What obesity is? It's a chronic multifactorial, multidimensional syndrome characterized by an inappropriate percentage of distribution of adipose tissue associated with multisystemic comorbidities and complications which require long-term mitigation and management. More than 1 million people worldwide are living with obesity. India is experiencing a rapid rise in obesity due to urbanization, sedentary lifestyle, dietary transition, then Zomato, Swiggy, and other dietary habits. Pathophysiology, that is energy imbalance and genetics. And what energy imbalance means? Obesity develops when energy intake is consistently exceed the energy expenditure, when the calorie intake is more than the utilization. Then the genetic factors account for almost 40 to 70% of obesity susceptibility. And then gene involved include leptin, MCR4, and FTO gene. Then there are neurohormonal regulation for obesity, that is leptin, which promotes satiety, ghrelin, that stimulates appetite, insulin, regulates glucose metabolism and fat storage, GLP-1, that delays gastric emptying and promotes satiety. Then there are environmental factors like sedentary lifestyle, sleep deprivation, stress, and ultra processed foods. Then the important part, that is clinical assessment, that is weight history and dietary assessment. Weight history, what age of the onset for the obesity, maximum lifetime weight of the patient, then rate of weight gain, previous weight loss attempts. Then there is a dietary assessment, what daily calorie intake patient is having, then the meal frequency, how frequently patient is taking the meal, then outside eating habit, that is eating outside other than the home food, then sugary beverages, binge eating behavior. Clinical history, that is physical activity, sleep, and personal history. Physical activity assessment, occupation related history, that is, there are many occupations which are very sedentary, like the shop workers, which are commonly we see they are very much obese. So they are in a sitting profession for a longer duration. Then exercise duration and intensity. Then sedentary time. Then sleep history, snoring, daytime sleepiness, witnessed apneas, psychological assessment like depression, anxiety, emotional eating disorder. Then medication history, there are certain medication which prone to increase weight like corticosteroids, insulin, sulfonylureas, antidepressant, antipsychotics. And there is a family history of obesity, type 2 diabetes, hypertension, or any cardiovascular diseases. Physical examination. When a patient visit to your OPD, what exactly you are supposed to see in a patient? Normally, what we see is weight of the patient to label the patient as obese. So weight is the important criteria, but not only the weight. There are other parameters as to 22.9 kg per meter square. We label patient as overweight when the BMI is 23 to 24.9 kg meter per square. Then obesity more than 25 kg per meter square, it is labeled as obesity. And there are three grades in obesity, grade 1, grade 2, grade 3. Grade 1 is 25 to 29.9 kg per meter square. Grade 2 is 30 to 30.4.9 kg per meter square, and more than 35 kg per meter square is labeled as grade 3. Why we need this grading for the obesity? According to the grading of the obesity, the treatment modalities change. So that's why we need to grade the obesity. Then BMI alone does not reflect the body fat distribution or metabolic risk. Patient with the same BMI may have different cardiometabolic risk. Then physical examination. Waist and hip measures. Waist circumference, that is measures abdominal obesity. Asian cutoff is men more than 90 centimeter and women more than 80 centimeter. Then hip circumference measure at the widest point of the buttocks. And there is a waist hip ratio. Abnormal values for men is more than 0.9 and for females that is 0.85. Then waist height ratio, higher cardiometabolic risk if the ratio is more than 0.5. There is a skin fold thickness measurement with the help of caliper that measures the thickness of the skin and subcutaneous fat at standardized sites with skin fold caliper to allow estimation of body fat. In general examination and signs of secondary obesity, vital signs like blood pressure, heart rate, respiratory rate, and there are signs of secondary obesity. What we commonly see is acanthosis nigricans. There is a blackening, velvety skin over the neck, underarms. Then Cushing syndrome features like moon face, buffalo hump, purple stripe over the body. Then hypothyroidism, dry skin, bradycardia, delayed reflexes. Then PCOS, which currently labeled as POMS, polyendocrine metabolic ovarian syndrome, that is hirsutism, acne, menstrual irregularities, acanthosis nigricans. Then evaluation for the secondary causes of obesity. Metabolic causes like type 2 diabetes, hypertension, dyslipidemia, NAFLD. Then cardiovascular causes like ASCVD risk assessment. Respiratory causes like pulmonary function test, polysomnography, that is sleep study for OSA. Then gastrointestinal, ultrasound abdomen, fibrous scan if indicated, upper GI scopy, and then psychological assessment, which is nowadays very important. That is depression, anxiety, binge eating disorder, or alcohol use. Then what laboratory evaluation we do after the body assessment? That is glycemic assessment, fasting blood sugar levels, postprandial blood sugar levels, HbA1c, lipid profile, that is total cholesterol, LDL, HDL, and triglyceride. Then renal function test, serum electrolytes level, liver function test, thyroid profile, that is TSH, FT3, FT4. Additional test what we require is vitamin D, B12, and uric acid. Then assessment of cortical axis, that is serum cortisol level, which we usually do early morning 8 a.m. sample, because cortisol excess is also leading cause of the obesity because of the stress. Then chest X-ray and ECG, sleep apnea assessment, USG abdomen, and upper GI scopy. Then assessment of body composition, that is bioelectrical impedance analysis, that is a BIA machine which measures the fat mass, fat-free mass, skeletal mass, visceral fat, non-invasive. It is a quick, inexpensive method that also measures your muscle strength, which is nowadays like sarcopenia and everything. So muscle strength is also calculated with the help of BI. Then DEXA scan, that is the gold standard for body composition assessment, major total body fat, lean mass, and bone mineral density. CT MRI, best assessment of visceral adipose tissue, but it is expensive. That's why we are not usually use it. So we commonly use in our clinical setup, that is BIA, that is inexpensive. So there are machines like in range of 7 to 8,000 that you can usually avail at your clinical setup to start with the treatment for the obesity patient. Then there is obesity staging, that is Edmonton obesity staging system. Stage 0 is no risk factor or symptoms. Stage 1 is subclinical risk factor present. Stage 2 is established obesity related disease. Stage 3 is significant end organ damage, and stage 4 is severe disability due to obesity. Then there are clinical phenotypes of obesity. That is MHNW, that is metabolically healthy normal weight. Metabolically healthy obesity, obese individuals without any metabolic abnormalities. Then metabolically unhealthy obesity, obesity with diabetes, hypertension, dyslipidemia. Then there is a sarcopenic obesity, excess adiposity with reduced muscle mass. Patient's weight is maybe normal, but patient may look centrally obese. So that is the severe form. Then normal weight obesity, normal BMI but increased fat percentage. So there's a picture showing 6 metabolically healthy normal weight, metabolically unhealthy with normal weight, metabolically healthy overweight, metabolically unhealthy overweight. Then MHO is that metabolically healthy obesity and metabolically unhealthy obesity. Then there are complications of the obesity. What exactly the complications are? Metabolic and cardiovascular, like type 2 diabetes, dyslipidemia, metabolic syndrome, NAFLD, hypertension, coronary artery disease. Then respiratory causes, respiratory complication, that is obstructive sleep apnea. There's a loud snoring, daytime sleepiness, and there's a stop bank questionnaire if the patient come with you with the episodes of apnea or hypopnea.
जी जी उसको स्लाइड शो करो शेयर स्क्रीन में ले जाना जी जी जूम में चलो जूम में जाओ
एक मिनट हो गया अब देखिए आ गया क्या आ गया यस
Yes, he continues.
यस यू स्टार्ट फ्रॉम
Then there are complications of obesity like respiratory and musculoskeletal complication, that is obstructive sleep apnea. We see commonly the obese patient, they start sleeping during the daytime. So there's a loud snoring, daytime sleepiness, and there's a stop bank questionnaire if the patient presented to you with apnea. Then obesity hypoventilation syndrome. In this patient, ABG may show hypercapnia, there's raised CO2 levels, and hypoxemia, that is raised decreased O2 levels. Then osteoarthritis commonly affects knee, hip, and spine. Sarcopenic obesity, that is excess fat mass with reduced muscle mass and strength. Assessed via hand grip strength, SARCAP questionnaire, and EWGSOP criteria. Then we follow the 5A model, that is comprehensive obesity assessment. That is ask permission to discuss weight. Not directly if the patient come with you or with overweight, we directly start questioning the patient. You are overweight, we need to start the treatment. So first take the permission to discuss about the patient's weight. Then assess, identify the causes and complication, advise, explain health risk and treatment option. Then agree to set a realistic goals, not to jump like to the ideal goals. Set the goals according to the patient need and according to the patient's capability. So the patient can fulfill the goals. And the assist provide a long-term support to control the weight and to avoid the complication related to obesity. Take home message. Obesity is a chronic disease, not merely a lifestyle problem. BMI alone is insufficient. Assess waist circumference and body composition. Screen for secondary causes and obesity related complication. Evaluate cardiometabolic, respiratory, musculoskeletal, and psychological health. Use a comprehensive patient centered approach for the diagnosis and management. Thank you.
time for the yes sir you can ask the question yes
Maybe, sir, with the adaptation with the newer environment, like our body is always adapt to the newer environmental system. So maybe the obesity without complication can occur in the future generation, because the previous, like nowadays we are seeing there are many food adulteration is happening. So nowadays we are not getting any original food substances to eat. So maybe in the future obesity can happen without complications. So we can say if newer generation can come with the obesity but without complication. If there is no complication, that we label it as healthy obesity. So that can happen.
You put some like sarcopenia, non-sarcopenic and sarcopenic obesity.
Sarcopenia. It's my Actually my PhD topic was on the similar thing. Sarcopenia and type 2 diabetes mellitus. Basically, what sarcopenia is, it's basically reduced muscle strength and muscle mass. So after starting like obesity with sarcopenia is the patient is looking obese. Like there's a central obesity. Patient का पेट अच्छा खासा बड़ा दिखेगा, but the patient is sarcopenic. There is a no muscle strength and muscle mass is less. So sarcopenia is the worst complication of obesity. So that is the worsening part. So sarcopenia with obesity is more dangerous than obesity without sarcopenia. So there is a terminology sarcopenic obesity. So that is nowadays we are seeing the flush of the GLP-1 drug. So with that, sarcopenia is mostly seen. So in those patients, we need to treat sarcopenia as soon as possible to avoid the further complication, because it is again rising the insulin resistance and other metabolic complication as well. So sarcopenia, like if the patient is looking thin with the periphery, so still we need to advise the patient with the protein supplement to avoid the sarcopenia. Not considering the patient is already obese, how can we advise protein diet to the patient? To reduce the obesity, still we need the protein diet and strengthening exercises. I mentioned there is a SARC score, that is strength. Just a second, I'll show you the slide. See, sarcopenic obesity, there is an excess fat mass with reduced muscle mass and strength. So there is a assessed via hand grip strength. That is a SCAR-CAP score and EWGSOP criteria. That is European group of people who are working on sarcopenic older patient. Older patient means more than 40 years of age. So there's a proper questionnaire. So S is for strength, access to work, then restriction to activity, then there's a chair test, and there are history of repeated falls. So according to that questionnaire, we can label patient with sarcopenia, without sarcopenia. So there is a questionnaire. So you can use that questionnaire to assess whether the patient is having sarcopenia or not. So that questionnaire is available online as well. Just mention SARCAS score and EWGSOP criteria. So according to that, you can access a bedside questionnaire based screening for sarcopenia. Thank you, sir. Thank you.
Sir, you have a question? That arrived that is something that is going to concern upbringing of the pedestrian. We can move back into the straight. Find that there are highly developed civilization. What we are seeing now is a highly developed civilization which is suffering from poverty. It is an outcome of the civilization development. So there was a civilizational development in the past also. So was obesity the problem then? And if not, why it wasn't a problem?
Because that time obesity was not problem, because civilization was there, but physical inactivity was not there. See, nowadays we are having phone, using banking on a phone, like we order Zomato, Swiggy. At least we have efforts during that civilization, but right now everything is available just a click. So that's why civilization is a problem with obesity nowadays, not the in the previous civilization. So we are ready to just order everything at home. We don't want to go outside. We don't need to take efforts. So that's why obesity is the issue nowadays with civilization. Thank you so much.
Thank you very much, ma'am. So, I request Dr. Erar sir to kindly felicitate our speaker. Yeah.
She has really presented very well. Alhamdulillah. You have answered the questions very well.
Thank you so much.
Thank you very much, sir, and thank you, ma'am. So we'll take a 5 minutes break because we were having some technical glitch into the Zoom, and then we will connect it again. So with this, we have come to the end of our session. Now, I would like to request all of you to kindly keep your cameras on so that I'll take the attendance. Speakers, these are the people who have joined online with us. Dr. Pawan, I see you and I expect questions from you. Thank you, everyone. You can switch off your cameras and kindly keep your mics off. We have done with our first attendance. The next attendance we will take after the third or fourth talk. Our next speaker is Dr. Syed Shahnawaz. Sir is DNB cardiologist and currently working as consultant interventional cardiologist at Icon Multi-Specialty Hospital. He has got a great experience of 8 years in interventional cardiology. Sir is was a consultant cardiologist at Care Hospital, Hyderabad, and have done his DNB from the Care Hospital itself. The areas of expertise that sir is having is from coronary angiography and angioplasty, left main interventional, then bifurcation intervention, and complex and high risk PCIs. Sir is also associate professor at Indian Institute of Medical Science and Research in the Department of Medicine. So I request Dr. Shanawaz sir to kindly take the dais for his talk. Are the slides visible online? Okay. The slides now visible. I hand over mic to sir. ऐसा ही आएगा फुल स्क्रीन नहीं फुल स्क्रीन यहाँ से आप चेंज कर सकते हैं यहाँ से उसको छोटा कर सकते हैं ये विंडो को क्या
Good morning, everyone. So today my topic is obesity and cardiovascular disease. So we'll look into some pathophysiology and some pharmacotherapy in this topic, and also what obesity does to cardiovascular disease. Madam has made my task easy as she has explained in detail the pathophysiology of obesity and the types of obesity. So I need not repeat those things. And I'll be mainly speaking because obesity is a very common problem in last few decades at least. But the renewed interest since last few years is because of some new drugs, some new publications in obesity, basically. And I'll be speaking mostly on those publications and what they actually tell about obesity and the drugs which are coming for obesity and what is their cardiovascular profile and cardiovascular advantages. So I'll be speaking on these trials which were published in NEJM in last 4 years. So first of all, let's challenge what we think and what we know. So the first thing what we used to learn is obesity paradox, that don't push weight loss in heart failure. But actually, it's something called reverse causation. Means in heart failure, the more sick patient they tend to lose weight, and because of that, the patients who are having more weight in heart failure, they're suffering from less severe heart failure. And because of that, it looks like obesity is better tolerated. Heart failure is better tolerated in obesity. So it's not actually like that. The long-term prognosis stay worse in obesity and heart failure. The second myth is GLP-1 receptor antagonist are only for diabetes. So we have now evidence from randomized control trials that it is now recommended for non-diabetic cardiovascular disease patients and with reduction in MACE of about 20%. Second, weight loss drugs are cosmetic, not medical. It's not like that. They are now a part of medical therapy with reduction in CV death, reduction in MACE, reduction in heart failure with preserved ejection fraction outcomes. We'll learn more about it in further slides. The second myth is the most important myth is try lifestyle first and drug only if it fails. Now, the latest recommendation 2025 of ACC is pharmacotherapy is now first line drugs, first line therapy in eligible persons. It is more effective in preventing outcomes than lifestyle changes. BMI alone defines obesity. It is wrong. Many other factors like waist circumference, especially in Southeast Asian patients, and the cutoff for us is lower than the Western population. One more myth is hold GLP-1 receptor under one is before cath lab procedures. It is cardiotoxic. It is not like that. It is only for aspiration risk. So we'll start the presentation with a case. So there was a 55-year-old male with a high BMI, hypertensive, non-smoker, presented with non-STEMI. We took him to cath lab. There was triple vessel disease. And PCI was done to two vessels, LAD and RCA. Circumflex was left on medical management and he was discharged on standard therapy. What was never discussed was his weight, 105 kg and BMI, and no anti-obesity referral was done. No pharmacotherapy was considered at discharge for this patient, nor it was planned in future. So what happened that 6 months later he came back with progressive dyspnea on exertion. He was unable to climb flight of stairs, bilateral ankle edema. His echo was still normal, but his pro-BNP was high. So diagnosis was heart failure with preserved ejection fraction, obesity phenotype. Now this is a very common missed diagnosis. We all have seen patients in our OPD, obese patients complaining of breathlessness on exertion. We do their echo, it is normal. We do pulmonary evaluation, it is normal. Still patients tell that it is just breathlessness and pedal edema. We think that it is due to obesity. It is due to obesity, but it is due to heart failure with preserved ejection fraction in obesity rather than just obesity. So we need to know this phenotype. What we should have done is at discharge, we should have documented obesity as a medical condition. We should have initiated semaglutide. We should have documented the weight loss. Even more than 5% weight loss would have reduced BP, inflammation, LV load, and would have prevented this episode. This wasn't unavoidable. So the global burden is very high, and even Indian burden is very high nowadays because of our lifestyle choices. And it is a number one driver of heart failure with preserved ejection fraction worldwide. The relative risk of diseases with more than 30 AMI increases a lot. Like hypertension increases 3 times, heart failure increases 2 times, coronary artery disease, stroke, atrial fibrillation, everything increases. And the increase is according to the class of obesity. It is neutral with normal BMI and it is very high with class 3 obesity. And in South Asian population, Indians, the BMI thresholds are low. The waist circumference thresholds are low as compared to the Western population. So obesity is a driver for 6 major cardiovascular diseases. Number one is hypertension. It increases the prevalence of hypertension 3 times. You may have seen that most of the obese patients who are diabetic will also be hypertensive. You rarely see a patient who is obese and only diabetic. So it is because of RAS and sympathetic activation, sodium retention. Heart failure, especially with preserved ejection fraction, is this due to LV volume overload, LVH. Coronary artery disease increases due to increased insulin resistance, dyslipidemia, inflammation. Atrial fibrillation increases because of obesity. There is LA enlargement, atrial fibrosis. OSA, which madam has discussed, is a major factor in increasing atrial fibrillation in obese patients. Stroke increases because of endothelial dysfunction, AF, hypertension, sudden cardiac death increases due to autonomic dysfunctions and QT prolongation. So it is a two heat effect. The disease is more and prognosis is worse. Both things are there. Like in hypertension, we have discussed that disease is more, and the outcome is worse because it is have they tend to have more resistant hypertension, faster LVH, accelerated CKD. Heart failure with preserved ejection fraction, they have more hospitalization, worse quality of life. Coronary artery disease, they tend to have earlier onset, diffuse disease, and higher restenosis rate after interventions. Atrial fibrillation, there is higher recurrence after treatment. As you may be knowing that atrial fibrillation, if it is intermittent, if it is non-structural, can be treated with ablations, radio frequency ablations, but the recurrence is very high with obesity. Stroke, obese people have larger infarct and poor functional recovery because of the issue with post-stroke physiotherapy and muscle weakness, sarcopenia, as Madam told. Sudden cardiac death is more common in obesity, and it also increases the incidence of sudden arrest in arrhythmias in arrest in obesity. So it is both incidence multiplier and prognostic modifier. So what is all this fuss about GLP-1 and dual GIP GLP-1 agonist? How they work? Actually, the two drugs which are now available in India is semaglutide and tirzepatide. Both work by appetite and working on appetite and satiety, by working on hypothalamic centers, decreasing hunger, increasing fullness, decreasing gastric emptying, and also they tend to increase insulin sensitivity. Glucose dependent insulin is increased, glucagon is decreased. And the add-on effect of GIP is it boosts insulin sensitivity and adipose handling, basically, and generates greater weight loss. So the net effect is weight loss of 12 to 23%, decreased visceral fat, decreased BP, decreased triglyceride, HSCRP, and improved insulin sensitivity. So what does it mean for cardiovascular health? So it is weight loss leads to event reduction. As you can see, the trials I have mentioned, the SELECT trial, it showed 20% reduction in MACE. It also showed CV risk reduction of 15%. The STEP heart failure with preserved ejection fraction trial of semaglutide, it has shown increase in 6-minute walking distance and also less hospitalizations. So, in obesity, the drugs, hypertensive drugs are also a little bit, they behave differently as compared to non-obese patients. Primary hypertension, out of which 65 to 75 can be attributed just to obesity. And every 1 kg of weight loss, approximately there is 1 mmHg of a decrease in systolic blood pressure. And with extra GLP-1 treatment, we can achieve more 8 mmHg of reduction in blood pressure. With the drugs of and with antihypertensive drugs in obesity, ACE/ARBs are first line treatment, and in addition, CCPs are a good option. Thiazide diuretics alone are not used; they can be used in combination with ACE. Beta blockers are best avoided as a single antihypertensive therapy in obesity, and spironolactone can be used in resistant hypertension. So in obese patient, routinely more than two or more drugs are used for resistant hypertension. Spironolactone can be added, and GLP-1 can contribute to additional 8 mmHg of systolic blood pressure reduction over these drugs. So it can treat obesity and also the pressure. Now, what obese patients we have challenges in cath labs with obesity. The most important challenge is difficult vascular access. As you know that many of the intervention require femoral access, and femoral landmarks we usually see on the skin and also on fluoro, the head of femur. These landmarks are obscured in obesity. Also, What do we do for that? We prefer radial approach. We use ultrasound guidance. There is poor fluoroscopy penetration in obese patients. Means image quality reduces in cath lab. The radiation dose increases. We try to minimize it by collimating and things like that. In obese patients in cath lab, there is usually more calcium and longer lesions, and it requires more usage of IBUS, OCT, and advanced things like rotablation. There is increased AKI risk in obesity. And for that, we have to prehydrate the patient, limit the contrast. CO2 angiography is also an option. And vessel sizing error is most common. The vessel size is underestimated in obesity because of the in obese patients, the image what we get and the comparison what we do with the chest size, it alters as compared to a non-obese patient. So, underestimation of vessel size is an important error, and for that also we need to use more IVAS and OCT. And post procedural complications in cath lab, there is higher hematoma and higher infection rate. Hematomas are, I may say that they are almost 90% of the hematoma patients will be obese and only 10% will be non-obese, because post-procedure we can compress artery better in non-obese patients, and the artery is difficult to compress in obese patients. So for that we tend to use more radial access, and we tend to use compression devices, closure devices. Now, the more devices you use, the more advanced things you use, you will increase the procedure time, you will increase the complications. So overall, in cath lab, there are many challenges because of obesity. Similar that obesity paradox in PCI, that better short-term outcomes were documented in obese patients, but the long-term restenosis and long-term events are worse. And as I have told earlier, that old GLP-1 is just because of aspiration risk and no other thing. Now, how did the obesity pharmacology evolve, and what are their effects on cardiovascular health? We have lipase inhibitor, which was neutral on cardiovascular health, opioid like bupropions, sympathogenic drugs. Sympathogenic drugs were better avoided in cardiovascular diseases because of tachycardia and things like that. Then came liraglutide. That liraglutide documented weight loss and also was cardiovascular safe. And then came the newer semaglutide and then tirzepatide. These showed better MACE rates, decrease all-cause mortality. So, because of all these publications which I showed you earlier, what the expert consensus of 2025 ACC guidelines, they have now recommended pharmacotherapy as a first line drugs in eligible patients, and do not require a try and fail of lifestyle before starting the drugs. So, because of these observation, now the pharmacotherapy is recommended as a first line, because the average weight loss in lifestyle, only lifestyle, was less than 5%. And with anti-obesity medications, we are now achieving a average weight loss of 20%, which is almost nearing to what we used to get with bariatric surgeries. And now newer drugs will be coming in a year or two, which would almost compete with bariatric surgery as far as weight loss is concerned. So now what does this weight loss does actually? Why we want to have a weight loss in a patient with cardiovascular disease? So if there is a 5% weight loss, you will have improvement in triglycerides, you will have improvement in blood pressure, you will have improvement in fasting blood sugar, you will have reduction in risk of incident of type 2 diabetes. This can be achieved with lifestyle. Average I am talking. There are many exceptions that people may lose more weight with lifestyle. There are many exceptions that people may not lose weight with lifestyle. So with pharmacotherapy, if you lose 10 to 15% of the weight, there is an improvement in liver diseases. There is an improvement in HbA1c. There is an improvement in OSA. There is reduced risk of cardiovascular disease. When you achieve 20%, you achieve reduction in cardiovascular mortality and heart failure events. And if you achieve 25%, there is reduced risk of all-cause mortality. So the reduction actually helps with the event rate. That's why we want more reduction, which is not usually achievable by lifestyle. So, what did the SELECT trial show actually? The first trial in non diabetic obesity patients. It showed reduction of MACE, primary events, of almost 20% in non diabetic patients. And it was considered consistent with all BMI subgroups, and it was partly independent of weight loss. We'll be talking about this in further slides. Okay, the benefits of these drugs are not directly linked to weight loss, they have additional benefits also. Then came tirzepatide, the dual antagonist revolution. With dual action, it achieved more greater weight loss than semaglutide, almost 47% more than semaglutide, and it had synergistic effects on decreased appetite, but also good effects on adipose tissue metabolism. So, and with dose titration, you can see you need to titrate dose from 2.5 to 15, and with more doses, more reduction was achieved in this trial. Both drugs were compared head to head, and there was significant more reduction in weight loss and waist circumference in tirzepatide as compared to semaglutide. Now, tirzepatide CV evidence was shown in two trials, SURPASS CVOT and Summit. SURPASS CVOT showed decrease all-cause mortality, decrease 3-point MACE, and also Summit showed better outcomes in heart failure with preserved ejection fraction. So comprehensive cardiometabolic benefits were decreased systolic blood pressure of 8 mmHg, decreased triglyceride, decreased LDL, increased HDL, decreased HSCRP, and decreased visceral fat. Now, important trial which is undergoing still and maybe results are expected next year is Surmount MMO, which is a trial in obesity without diabetes of tirzepatide, which is awaited next year. No, as we were talking previously about heart failure with preserved ejection fraction, two trials were done on heart failure with preserved ejection fraction in diabetic patient and in non-diabetic patient. Both trials showed that semaglutide increased quality of life and also increased 6-minute walking distance. And this effect was independent of what weight loss they achieved. That diabetic patients, they achieve actually 40% less weight loss as compared to non-diabetic, but they had anti-proBNP reduction, which was not explained by weight loss alone, consistent with weight loss independent disease modifying effects of GLP-1 path. So, what is beyond weight loss? How GLP-1 receptor antagonists protect the heart? They decrease inflammatory markers, HSCRP, they decrease vascular inflammation. They have direct cardiac effect. They improve myocardial energetics. They have improved endothelial function. They have reduction in systolic blood pressure. They have reduction in triglyceride, improved glycemia, more natriuresis, less plasma volume, less volume over. So this substantial part of the benefit is independent of weight loss actually. So thus, as suggested in trials, STEP, heart failure with preserved ejection fraction, diabetic trial, where the weight loss was not there, but still benefits were there in heart failure with preserved ejection fraction. So now regarding cardiovascular safety, so the drugs we are now talking about, semaglutide and tirzepatide, both are cardiovascular beneficial and cardiovascular favorable, as we have seen in previous slides. So what to do about these drugs around cardiac procedure? Suppose someone is planned for an elective angiogram or an elective PCI, you can hold this drug 1 week before because of only one thing, delayed gastric emptying and increase of aspiration release. There is no cardiotoxicity. In emergency patients, you can just continue the drugs. In emergency patients who are vomiting, you can stop the drugs. And post MI, you can start after 4 weeks. It is well studied in stable cardiovascular diseases, still not studied in acute MI. Post bypass also you can restart. Post AF conversion, it is recommended because the more weight loss improves cardioversion rate. and it has no interaction with antiplatelets. So now post-select trial, which showed that initiating semaglutide in stable cardiovascular patients without diabetes is now evidence-based standard of care. It is not just a you do weight loss for cosmetic purposes. It is because of evidence that it reduces cardiovascular. Now, as per like end of 2025, what do we start and in whom? So in non-diabetic cardiovascular diseases, still semaglutide has evidence. Tirzepatide evidence is coming, and the cardiovascular benefit trial is going on. Maybe it will be published next year. So with diabetes and cardiovascular diseases, tirzepatide is preferred because of superior weight loss. In heart failure with preserved ejection fraction and obesity, both can be used, both have better outcomes. And in intolerant and refractive patient only, we need to escalate or send for bariatric surgery. What is the role of bariatric surgery? That only when drugs are not enough. That if BMI is more than 40 or more than 35 when patient is having OSA, heart failure, diabetes, dyslipidemia, or it is even being studied less than 30, just less than 35 BMI also from 30 to 35, and it is only on failure of pharmacotherapy plus lifestyle for more than 6 months. But there are lot of post-op issues in bariatric surgery, especially with the absorption of nutrients and also with the absorption of drugs. So this bariatric surgery decision needs to be taken very carefully, and even after trying all the pharmacotherapy which is available with lifestyle. So what's coming? The next generation obesity drugs, as I was talking about, some oral drugs have been approved with US FDA, orforglipron, and retatrutide is being studied now, and it is shown to have now 28% reduction in weight, almost as comparable to bariatric surgery, and the trial is going on. Now, these things will come in next few years, and we will know more about these drugs in future. So, with this presentation, what we need to do differently? That first, screen every cardiovascular disease patient for obesity, waist circumference, not just BMI. South Asian cutoffs are lower. Second, stop waiting for lifestyle failure. It rarely works, and pharmacotherapy is the first line drugs in eligible patients. Start it now. Non-diabetic cardiovascular disease plus obesity, semaglutide can be started. It reduces MACE by 20%. Now this is evidence-based standard of care. Diabetic plus cardiovascular disease plus obesity, tirzepatide should be considered because of superior weight loss as compared to semaglutide. Heart failure with preserved ejection fraction, if you diagnose it by increased NT-proBNP, you should treat aggressively with both the agents are equal in this disease. Before elective PCI, assess weight, discuss management, and you have to hold GLP-1 receptor antagonist 1 week pre-procedure. Never use phentermine or other drugs in cardiovascular diseases which are sympathomimetic. And tell your colleagues that you need to discuss about this pharmacotherapy first approach, because this thing is difficult to digest, especially for the people who are practicing since 10-15 years, that we were trained in such an environment where we used to know there were no effective drugs, and the cardiovascular safety of those drugs were not studied thoroughly. So now to shift to this mindset where pharmacotherapy first in obesity is a little bit difficult, and we need to look at the evidence, we need to look at the publications, study them more thoroughly, and all these publications were which I talked about in my presentations were done in NEJM, not in random journals. So you need, at least we need to discuss these things and keep on studying if you are not starting it right now. So these were the references in my slide. So it starts with one patient, one conversation with patients, and it leads to one prevented MI. And we need to remember that obesity is not a lifestyle choice. It is a chronic neurobiological disease with profound cardiovascular consequences. Evidence is there for treatment, drugs are there for treatment, guidelines have changed, and we should not wait for treatment. And those who are interested to read further, this is a very good consensus which was published by ACC last year, and it is regarding the medical optimization for in obesity for cardiovascular death. You can download this. So I'll stop with this, and any questions happen. Yes, sir. Yes, sir. So it works both ways. That some antidepressant drugs even they lead to increase in weight also. And thing with obesity and depression is, okay, yeah, just using antidepressants will work or not. It's difficult to say. We need to switch to lifestyle choices and antidepressants and maybe try for some time. But if the patient is having established cardiovascular disease, then maybe we should think of starting these drugs first rather than trying antidepressant, because there is no clear evidence or trials, large randomized control trials of antidepressants in obesity preventing cardiovascular mortality. We don't have evidence yet. So here we have evidence, and it doesn't just the thing about mental health mentioned in all these trials that you need to titrate the drugs which are used in depression and anxiety in the patient who are losing weight, because the drug requirement will lower down with as the weight is coming down. So only that thing is discussed in these trials, and there is actually no published evidence of the drugs of depression working for reducing obesity or for reducing cardiovascular mortality in obesity. So, most of them who are we don't know what these drugs are actually. Many of them are combination of these symptomimetic drugs, maybe, or maybe the things which just increase gastric motility and reduce the absorption, things like that. So we don't have any concrete evidence that these things work, or and many of those may lead to renal issues, as we have seen with alternate medicine. So difficult to comment. But the weight loss we are seeing with GLP-1 in last 2 to 3 years, we have never seen with any other agent in last 15 years. That is for sure, sir. Because these patients are responding very good. The requirement of anti-diabetic drugs are coming down. The requirement of insulin is coming down. Many patients are getting free of OHS. So there is tremendous benefit, not in all patients, but almost majority of patients you can tell. So we have not seen such benefits in previous drugs, especially in alternative medicine, consistently. Yes, now with BMI, sir, the madam in last lecture she has given us a table regarding the grade of obesity, and also apart from BMI, waist circumference is an important thing which should be considered in obesity. Like it is 40 inch for Western population, more less for Indian population. Even height height ratio with waist circumference has been used. So more focus is shifting to central obesity rather than BMI in these years, because that is what is harmful, the central obesity. Okay, since you are an avid user of GLP-1 agonist, so maybe some comments from. Acha, he has a lecture.
So, with this, I thank our speaker and I request Dr. Leikur Rahman sir to kindly felicitate our speaker, Dr. Sayed Shano. So, with this, we have come to end of our second session.
diagnosed. But if you see the figure of obesity, actually here you can see the abdominal obesity is coming to the tune of 35 crores of patients among 240 crores. And if you see the general obesity is about 25%. So the incidence of obesity is very, very high as compared to the diabetes and pre-diabetes actually. Now we have to accept obesity as a separate disease. Actually, it is the mother of all metabolic illnesses, right from the diabetes, pre-diabetes, hypertension, dyslipidemia, cardiovascular illnesses, stroke, peripheral vascular disease, and all n number of diseases are associated with obesity. And now there are clear-cut guidelines to diagnose obesity, how to get investigated regarding obesity, how to avoid obesity, how to use the pharmacological therapies, and how to go for the surgery. So it is like a separate disease as we are treating diabetes, as we are treating hypertension, as we are treating cardiovascular illness, now we have to treat the obesity actually. So we need to upgrade our knowledge as far as the approach of obesity is concerned. That is my basic idea actually. Right? So these are all the burden of the disease in India. If you see the general obesity in India, it is 31% generalized obesity in women, 25% in men. But if you see the abdominal obesity, it is 49% in women. So 50% the females are having central obesity, and it increases the risk of further metabolic illnesses. So diversity, wherein one in four adults are now overweight or obese. I'm not going to not going into the detail of the balance and the benefit. So obesity is also due to multiple complications. These are the known complications what we are facing day-to-day life: diabetes, pre-diabetes, hypertension, obstructive sleep apnea, PCOD, infertility, the osteoarthritis, fatty liver. All these are the common entities, and we have got now good medications to reverse this stage of obesity. So it is an interrelationship can become the combination of diabetes and obesity can become as a diabetes, and we have to separately. The most important thing as a Asian Indians, we should not have channels that we already spoke about. We Indians are different as compared to Western population. We developed diabetes 10 years before as compared to Western population. Our total body fat percentage is very high as compared to the Western population. At lower BMI, our research fat is very high. That is the reason why we are more insulin resistant as compared to Western population. Our conversion rate of pre-diabetes to diabetes is very high. So the younger population is getting affected very highly due to obesity, and with this background of genetic constitution, our environmental factors play a great role, the psychological factor, lack of sleep, multiple addictions, day-to-day stress. All these are the factors which are increasing the incidence of diabetes and metabolic diseases in our country actually. So this is the concept of thin fat Indian, what I have already mentioned. At lower BMI, our visceral fat percentage is very high, and that visceral fat is metabolically thin, and that causes the metabolic illnesses actually. So the treatment now, we have to target this total body fat percentage and visceral fat so that we can prevent the further progression of the metabolic illnesses actually. So this is the metabolic how this visceral fat now fat as fatty cells are the endocrine organs, and they secrete multiple pro-inflammatory cytokines, cytokines, and lipoprotein metabolites, and they causes the organ damage and leads to multiple illnesses. So this is the traditional approach, initially what we used to do in diabetic patients, we used to control blood sugar levels. So for now, the guidelines have mentioned that you have to approach the diabetic population not as a glucocentric approach, but you have to target it for weight. Then we have to do the control blood sugar level is equally important to control the blood pressure, is equally important to control the liver, it is equally important to control or protect the liver, it is important to control the heart and the kidney sector. So we have to use the therapies in such a way that it will not only control the blood sugar level, but simultaneously they should give some benefits as far as weight is concerned, it should be some benefits as far as cardiovascular metabolic health is concerned. So how we have to approach as we have the repetition of the slides because now we are discussing only two good molecules like semaglutide and peptide, and the data is same as shared by the Dr. Shahana Wasser. So, at what tune of the weight loss it is required for the control of the metabolic problems actually. So, dyslipidemia, if the patient control the weight to the tune of 5%, to start with in the initial 6 months is fair enough, give small targets to the patient. Then next 6 months, if you achieve that 5% weight loss, give them the target of next 5%. And our aim is to control the weight 15% from the baseline actually. So that 15% weight loss is recommended, and the metabolic benefit starts right from the 5% weight loss actually. So 5% weight loss, the glycemic control gets improved, hypertension gives benefits, and the 15% weight loss, CV risk reduction will be there at around 15%. Type 2 diabetes prevention or remission of type 2 diabetes will be there at 15% weight loss. The improvement in osteoarthritis, sleep apnea, it will come by 10 to 12% of weight loss. Gastric esophageal reflux, it will show benefits by 10 to 12% of the weight loss actually. And the PCOS, the PCOS is now changed to PMOS actually, polyendocrine ovarian syndrome, and all these metabolic agencies gives rise to benefit at 15% weight loss. So first target of the patient should be 5% weight loss in initial 6 months, and then next 5% in the next 6 months, and 15% is our target. Generally, we see that with the evolution of this drug, that 15% weight loss will be achieved in 1 to 1.5 year actually. So we have to continue the therapy that to at least 1.5 year. So we have to prepare our patient in such a way that if we want to get the benefits of and these benefits in future for the prevention of this metabolic illness, it is a continuous treatment actually. After 1.5 years also, we have to guide our patients as a maintenance dose of the therapy. So as the diabetes is a chronic medical illness, lifelong treatment is required. For obesity also, we need to give lifelong treatment actually. We can titrate the doses of medications according to the patient's need, but our main aim is to control the weight up to 15 to 20% actually, and that needs time actually, and it is a gradual process. So if we don't control the scenario, if we don't use the pharmacological agent by this time, it is seen that we will be likely to get double the patients by 2048. So initial doubling of the patient will take have taken 20 years, but this doubling will take only 15 years actually. So the scenario is very dark, and we have to have clear approach in our mind to treat our patients. So treatment options available for overweight and obese diabetic patients. There is nothing, all diet, physical activity, behavioral therapy, pharmacotherapy, and metabolic surgery. So we take it one by one. So it has to have a structured therapeutic management approach, that is the lifestyle management, which contributes to diet and exercise. Diet, we have to give the diet that in all the patients, whatever trial has been done on this peptide and this semaglutide, they have reduced 500 calories from the diet, they have given a physical exercise, and on the top of that, they have titrated the dose of those medications. So we should not forget that if some patients are not responding, if some patients are not losing weight, so we have to encourage from that point of view that 500 to 1000 calories cut down the calories is required, and they have to do the regular exercise as well. So standard weight loss diet we have to give to the patient. In the diet also, we have to give carbohydrate to the tune of 50 to 50 to 55%. We have to increase the protein content. Protein has to be given 1 to 1.2 grams per kg body weight. Our diets are very much protein deficient, and fats to the tune of 15 to 20% actually. This is what the recommendation is. As far as exercise is concerned, it is very essential to do the aerobic exercises which are meant for the weight loss and to reduce the insulin resistance daily. 30 to 45 minutes walking is not recommended, and 150 minutes of walking in a week is what American Diabetic Association recommends. Whatever suits to the patients actually, walking, jogging, cycling, swimming, anything can be done. But along with that, these aerobic exercises are not sufficient. Along with that, they have to give the at least 3 sessions of the resistance exercise to increase the muscle strength actually. And as these medications causes the weight loss, particularly fat loss, but they do causes the muscle loss as well. So lean mass will get reduced when the patient will lose up to 10% of weight loss, and if we are going for the further weight loss, we have to take care of sarcopenia as well. So in that circumstances, it is very essential to increase the muscle strengthening exercise and take a very balanced high protein diet actually. So what are the medications which are causing weight loss in obese type 2 diabetic patients? Number one is metformin, long-standing anti-diabetic, very trusted and very studied molecule with the robust data. It causes weight loss to the tune of 1 to 2 kg only. But it has got their own benefits as far as metabolic or hepatic glucose output reduction is concerned and controlling fasting plasma glucose is concerned. Second class is SGLT2 inhibitors. So what are these SGLT2 inhibitors? These are the novel anti-diabetic medications. What they are doing, they are increasing the renal threshold of glucose excretion actually. So our body has got a protective mechanism. After 180 milligram of rise blood sugar level, our body tries to remove that excess glucose through the urine. So there is a limit. After there is a limit of the body to that excretion activity. What these medications are doing, they are increasing the renal threshold of glucose excretion. So near about 180 gram of glucose is excreted per day in the urine of diabetic patients, and they will lose calories and they will lose weight also. They have some these molecules are canagliflozin, dapagliflozin, empagliflozin, and along with the weight reduction benefit. They do have some benefits in the blood pressure. They do have some benefits in the lipids, but the most thing is that DAPA and empagliflozin, they are cardio and lipoprotective medication. So the guideline says that in spite of glycemic control, if the patients are having established ASCVD, CKD, and heart failure, they have to be on dapagliflozin. Cardiac proven benefits of that molecule has to be there, like dapagliflozin and empagliflozin. So these are the medications which are mandatory for all diabetic patients who in whom cardiac illness is established and cardiac kidney problem is established. So these are the medications which are causing weight loss and giving cardiorenal benefits. As sir was talking about the psychological support to the patient. So behavioral therapies have got a very important role in the management of obesity actually. What we have to do from the patient, we have to counsel the patient properly, we have to track the patient for the management of anti-obesity therapy actually. We have to sit with the patient, we have to explain them what I was explaining you, what are the problems with the obesity and how this obesity will hamper your future quality of life. Right? So what are the benefits of 1 kg weight loss? What are the benefits of 5% weight loss? What are the benefits of 10% weight loss? How we have to approach in all the patients, diabetic or non-diabetic. The approach has to be same. So we have to track the patient. We have to educate the patient. What is the concept of visceral fat? What is the concept of total body fat percentage? What is the insulin resistance? Why diabetes is happening? We have to give this much level of knowledge to the patient. Then only we can prevent the 50% growth of development of diabetes in our patient. If you see the data, how many percent of patients of diabetes are under control of HbA1c? 7%. It is just 17% in all over India. Not only in all over India, in the world. Only 70 to 20% patients are under control of HbA1c. 7%. The rest of the 80% patients are not under control of HbA1c. So there is a lot of room for the improvement of the glycemic care as far as the diabetic management is concerned. And why this is happening? Because we are not intervening our patients, we are not tracking our patients for proper diet, proper implementation of exercise plan, and proper titration of anti-diabetic doses and step by step less use of insulin in our diabetic practice. Now with the emergence of such a wonderful drugs which causes weight loss and multiple pleiotropic benefits, we have to introduce these drugs very early in the management of diabetes so that we can pass on the benefits as per as development of other metabolic diseases are concerned. So we are not having fatty liver is very common. Fatty liver initially we were not thinking of fatty liver in our day-to-day clinical practice. And practice since last 15 years, I used to get all the reports, random reports of sonography, fatty liver in all obese patients. Fatty liver has increased to the tune of 50%. And now, initially, we were not bothered about what that fatty liver is causing of cirrhosis, and patients are going for the liver transplant as well. So, diseases has become very aggressive nowadays. The incidences, all incidences are increasing very fast actually. So, we have to halt the progressions of the diseases. These are the ADA guidelines 2020. They have clearly mentioned the weight loss management has to be there in all the patients in which we have to target the blood glucose, and after that we have to do the neurotrophic benefits of cardiac and renal protection. So, if I'm treating the diabetic patient for obesity, the results are slightly different. And if I'm treating the patient non-diabetic obese patient, the treatment are little bit different. The weight loss can be more difficult to achieve in diabetic patients because of few reasons. Right? Number one, the fear of hypoglycemia and compensating overeating will be there. There will be stress burden of diabetes in the patient. The medications like insulin, sulfonylurea, and TCA, they causes weight gain actually. So if we are, so we will not get the weight loss to the tune of that what we are getting in non-diabetic population, and reduction in the glycemia. All these are the factors they give the started weight loss in diabetic population with the uh, with these two molecules. Now I am going to discuss what I am doing in my day-to-day clinical practice as far as obesity is concerned. So these are the two molecules which I am going to discuss. One is semaglutide and one is tirzepatide. Now these two molecules are they act, they are the anti-diabetic medication, but their effect is weight loss, which is to the tune of 15 to 20%. So the proposed role of GIP and GLP regulation, and they act through the axis of GIP activity and GLP activity. So semaglutide, it is a GLP-1 receptor agonist, while tirzepatide is a dual agonist. It will act on the GLP-1 and GIP receptor both actually. And as I mentioned, now the few molecules which are acting through the triple axis, like they are glucagon inhibitors, they are acting through the amylase analog. All these are the molecules and pipeline, and they have a potential to reduce weight to the tune of 25 to 30%. So semaglutide is a selective GLP-1 receptor agonist. It is available as Ozempic and Wegovy. Right? Ozempic is to be used in the diabetic patients. It is available zero point 0.5 and 1 milligram. It is for glycemic. So if you want to go for the weight loss, you have to use the higher version of the semaglutide that is available in the doses of 1 milligram, 1.7 milligram, and 2.4 milligram. The maximum effect, maximum dose of the semaglutide is 2.4 milligram. What we have to do is these are the injections, these are the injectable therapy. Semaglutide tablets are also available. I'll talk about that. Semaglutide, we have to initiate in the patient 0.25 milligram subcutaneous injection once in a week. The half-life of molecule is 5 to 6 days, so we have to use it once in a week. What it causes, it reduces appetite. It reduces the appetite, it reduces hunger, and gradually it causes weight loss. So initial weight loss in first month can be 1 to 1.5 kg. In the second month again 1 to 1.5 kg. By 6 or 8 months, patient will lose near about 7 to 8 kg of weight loss actually. So every monthly we have to up titrate the dose of Ozempic. Right? So in the first month it is 0.25, then in the next month 0.5, then 1 milligram, then 1.7 milligram, and then 2.4 milligram. So gradually patient will lose. So when we are using this molecule, we are supposed to we are supposed to reduce the dose of OH to the tune of 10 to 20%, and in weight loss benefits will start and patient will reduce the doses of insulin and oral hypoglycemic agent. So this is the semaglutide. Now, how it is going to benefit the diabetic patient? The semaglutide has got a potential to reduce HbA1c to the tune of 1.2 to 1.5% from the baseline. So this is a very potent anti-diabetic. So in the low doses and in the higher doses up to the tune of 1 milligram, it has got potential to reduce HbA1c 1.5 to 1.8, and weight reduction is 4.5 to 6.5. So these are the step trials of the semaglutide, which has compared semaglutide with the placebo. They have compared with the semaglutide with the they have studied in the Asian Indians. They have studied with the vildagliptin. They have studied the molecule with the trispeptide and liraglutide as well. And we have seen that it causes weight loss to the tune of 50 to 70%. The sustained trial has studied for the glycemic control, and it has compared the molecule with the placebo 1.6 percent reduction from the baseline in the 30 weeks with the zero point 0.5 milligram, and with the maximum dose like 1 milligram we can get the HbA1c reduction to the tune of 1.8 percent. Now here you can see the molecule is studied with the sitagliptin, studied with the
The maximum weight reduction with the semaglutide is up to 14 to 16% with the maximum dose of 2.4 actually. And near about 70 to 80% patient achieve this target at the end of 72 weeks actually. Now the semaglutide is also available as a oral tablet form actually. It comes with the name of Rebelsus. So it is available 3 milligram, 7 milligram and 14 milligram. So we have to give this tablet 3 milligram to start with on the empty stomach with the glass of water. Again, it will causes the reduction in the hunger, and it will causes the it will reduce the hunger, and gradually it causes the weight loss actually. So in the first month we have to use 3 milligram, then 7 milligram, and then we have to go with the 14 milligram. The potential of 14 milligram of oral semaglutide, that is the Rebelsus, is slightly less as compared to 2.4 milligram of the injectable therapy. So here you can see the weight loss is 14% with the oral preparation, and up to 15 to 16% with the injectable therapy. Injectable therapy compliance is good. It is once in a week, and oral tablet has to be given on the daily basis. So, coming to the trispeptide, this is the trispeptide is a dual agonist. It acts to the GIP and GLP-1 molecules. But the benefits of the trispeptide, like one more thing I would like to mention over here. The cardiac benefits of semaglutide are good, as sir has already mentioned. So it is an approved medication to use in cardiac patients actually. The data of the trispeptide is lacking, and the trials are in the pipeline, and so we'll get the data of trispeptide. It is definitely going to help the cardiac patients as well. The data is pending, and we'll get the data in a couple of years. So it will also get an approval. By that time, semaglutide is approved agent for fatty liver and the cardiac patients for type 2 diabetes. Now coming to your pick, this trispeptide is available as a Monjaro and your pick. The Monjaro is the product developed by Lilly, and they have sold it in the India to Cipla. The molecule is available as a injectable therapy, 5 milligram, 10 milligram, 12.5 milligram, and 15 milligram. Again, it is to be used as a subcutaneous injection once in a week. Gradually up titrate the dose. Again, it will causes the suppression of appetite, and gradually it gives rise to the weight loss, particularly the way among the weight loss. What is important is the total body fat percentage loss actually. So what we are doing in our day-to-day clinical practice, if obese patient comes to us, we'll get evaluated patient for the metabolic illnesses like diabetes, blood pressure, hypothyroidism, lipid profile, baseline LFT, KFT, sodium, potassium, where we are doing. We'll see that whether this obese patient is linked with the other metabolic illnesses, number one. Number two, we'll get done is body composition analysis. What is this body composition analysis? It gives the idea of among the 100 kg, suppose patient is 100 kg, how much weight is contributed by total body fat, how much weight is contributed by the muscles and bones, and what is the percentage of visceral fat, how much is the waist circumference, and what are the target weight of that particular patient. So this machine will give you idea regarding the total body fat percentage, number one, and number two, visceral fat. Before starting therapy, we are doing this BCA, and we are starting therapies to the patients actually. So what are the indications of the patient? As madam has already mentioned, obese type 2 diabetic patient, early management of uncontrolled type 2 diabetic patient with the risk of cardiovascular illnesses, with the risk of kidney diseases, patient with obstructive sleep apnea, patient with PMOS, a patient with fatty liver, patients with osteoarthritis. These are the indications for these type of the patients actually, because they have got potential to reduce the body weight up to 22.5%. So we can see here the 5 milligram of trispeptide can reduce weight to the tune of 16%, 10 milligram to the tune of 21% at the end of 72 weeks actually, and 15 milligram gives rise to weight loss of 22.5. So this much weight loss pill or molecule is not available till date. That is the reason why we were not able to target weight in either obese patients or or normally obese patients or diabetic obese patients actually. But these molecules are available. They are there in the market since last 2 to 3 years. They are not new molecules. They are available in US since last 3 years. They are now recently launched in India. Initially, these molecules were very costly. The therapy of this Monjaro was initially 40,000 rupees per month. So I'm using these molecules since last 2 years. When it was not available in India, we used to import it from Dubai, and from the Middle East, he used to come for selected number of patients. First of my patient has lost near about 35 kg weight loss. He is still continuing with the drug on 15 milligram. He has lost 35 kg. See, 35 kg weight loss with the injectable therapy is very rare actually. So this is the weight loss as comparable with the bariatric surgery, as sir is talking about actually. But recently there is a they have cut down the cost, and now this therapy is available. The first dose is available to 10,000 rupees. As dose get escalated, there is a slightly increase in the cost. 15 milligram is available at the cost of 20,000 rupees per month actually. But if you see the benefits, if you are taking this therapy for 1 to 1.5 year, and if you are reducing your weight by 20 to 25%, and if you are maintaining that weight loss, you are going to get tremendous benefits, metabolic benefits, number one. Number two, your quality of life will improve. Number three, the expenses what you used to do on diabetic medications, antihypertensive medications, uh,
the problem of the infertility will resolve, the problem with the PMOS will resolve. There are tremendous benefits of these molecules in day-to-day clinical practice. So this was the comparison, and the potential of the tricyclic is
is
that
that more
more than
than 25% weight loss will be seen in 39% of patients actually. 39% patient, and more than 20% weight loss will be seen in near about 70% of the patients. So it is a very potent anti-obesity medication. As the BMI is not only the sole criteria for the assessment of obesity, actually, it is the waist hip ratio is very, very important in Asian patients. And this waist hip ratio can reduce to the tune of 20 centimeters with this molecule by the end of 72 weeks, actually. So, 7 inches reduction in waist circumference is very, very significant. This not only reduces the total body fat percentage, but they reduces the systolic blood pressure, diastolic blood pressure. They improve the lipids. They improve the LDL, HDL, and triglyceride as well. Now coming to the lean body mass, actually, so total body fat loss will be there near about 34% with the use of 15 milligram of trizapeptide. Visceral fat has come down to 40% from the baseline, actually. So these are the two factors we have to always remember, and we have to compare these parameters in the body composition analysis. So what we are doing BCA in the beginning, after 6 months, and after 1 year, actually. So these are the molecules. Now, if you see the side effect profile of these molecules, right? Side effects are no, patient will always ask regarding the effect and side effect, actually. So as these molecules are acting on gastrointestinal tract, they causes nausea, vomiting, diarrhea. All these side effects will be there, but these side effects are not very common in day-to-day clinical practice. They are easily treatable with the small symptomatic dose of anti-emetic, antacids, and this type of things. And if you want to stop the medication for some time, then you can stop the medication. Again, you can start with the lower doses and gradually titrate the dose to the higher doses to achieve the maximum benefits, actually. So if you compare both the molecules like semaglutide and trizapeptide, so here you can see the mean percentage of change in the body weight with the semaglutide is 15.4%, and with the trizapeptide it is 21 points. So semaglutide has got the trizapeptide has got a edge as far as weight reduction is concerned, but it has got its own benefit as far as cardiac safety, indications in the fatty liver are concerned. Now here you can see the 25% weight loss can be more than 25% weight loss can be seen with the 36.2% of patients with the URPIC, that is the trispeptide, and in the semaglutide 20% patient can show the weight loss to the tune of more than 25%. If you see if you compare waist circumference of the two molecules, it is 14.7 versus 20 centimeters for the trizapeptide. So both the molecules are potent. If you see the cost of semaglutide, it is very less. It is available at one-fourth cost of the trizapeptide or Mounjaro. Actually, it is one-fourth cost of Mounjaro. So in India, what has happened and why the market is booming with the semaglutide? Now this molecule is available as a generic version of original semaglutide, and that is the reason why the cost has reduced drastically and the use has increased enormously. So the molecule, the Wegovy or Ozempic was available as a 5,000 or 6,000 rupees a month therapy as injectable. Even though the tablets are costing the same, the tablet is available for 2 to 300 rupees, 300 rupees a tablet, and so that cost has come down to 100 rupees. And now with the use of generic version of the semaglutide, it is now available an injection, and the vials are available in the cost of 1.2 or 1.5 thousand rupees per month, actually. So the use has increased. If you compare the side effect profile of semaglutide and trizapeptide like Mounjaro and Ozempic, the side effects are profile is comparable, actually, and they are easily treatable. So there it is not contraindicated. It is not a contraindication to use this molecule. Now, what are the real contraindications to use this molecule? If the patient is having medullary history of carcinoma of thyroid, we are not supposed to use, or family history of medullary carcinoma of thyroid, we are not supposed to use, as it is the component of MEN2. In MEN2, we are not supposed to use it. So MEN2 is contributed to medullary carcinoma of thyroid, pheochromocytoma, and the hyperparathyroidism. So warning warning signs like as these molecules increases the GIP and GLP-1 in acute pancreatitis, we are not supposed to use. In the patient with the history of pancreatitis, we are not supposed to use. There are links of the optic neuropathy with the use of this molecule, but the incidence was very less. It was to the tune of 1 to 2 cases in 1 lakh population. So it used to cause the already diabetic patients has got the potential to have this stroke of eye, that is an anion, and the links are linked to this anion is linked with the use of semaglutide and tirzepatide as well, but FDA has cleared it and the statistically risk is not there. So these are the warning signs for the patient. So whenever we are starting therapy, we get down the workup done properly, get down the USG, get down the biochemical parameters, get down the body composition analysis, start them, give them proper diet, give them a proper exercise implementation plan, and monitoring is very essential. Take brief history of thyroid medullary carcinoma and get done his fundus if required in highly suspected patients, and you can start this type of therapy. With the cost coming, we have to increase the use, so on, so that we can pass on the benefits of such a good molecules for our diabetic as well as non-diabetic patients. So this is all about the use of Monjaro and the Ozempic in our day-to-day clinical practice for our diabetic patients. Thank you very much for the patient hearing. If there are any questions, I will be happy to answer. Yeah. Yes. So as far as side effect profile is concerned, there are no side effects. As I already mentioned, the GI side effects are common: nausea, vomiting, and diarrhea. These are the common side effects. One more thing I would like to mention over here: if patient wants to get pregnant, we are supposed to stop this medication 2 months before the pregnancy. Actually, so whenever we are using some molecule during pregnancy, we are supposed to stop that medication 5 half life before 5 half life of that molecule actually. So it comes to the tune to 1.5 months, so before 2 months, and it is not supposed to be used in lactation. These are the two warning signs, or these are the two situations where we are not supposed to use this molecule. Lot of PMOS patients are coming to reduce the weight loss. Lot of patients with the before marriage, they are coming for the weight loss, and in that situation again we have to counsel them properly that these molecules are not studied in pregnancy and in lactation, so we are not using it. Number one. Number two, now you are asking about the maintenance doses. So if you are achieving target of 15 to 20% weight loss, if patient wants to take the maximum dose and if it is tolerable, we will continue with the dose, because there are benefits of more than 15 to 20% weight loss. Cardiac benefits are enormous actually. Number one. Number two, if patients wants cost effectiveness, there are no guidelines for the lower dose titration. Number one. Again, it is our experience that from the highest doses, we have to cut down the dose to the 50% dose and try to maintain it. But if the patients are developing symptoms of hunger, that means that a molecule is not sufficient to as the maintenance dose. Again, we have to escalate the dose. So it is all depends upon the individual patient's response actually, and we have to go according to that. If what happens if patients stop these medications, if patients stop this medication, there are studies, they will get rebound weight gain to the tune of 50% in coming 1 year. So why the medications are the anti-diabetic medications are not successful in India because whenever we are stopping these medications are number one, they are not supposed to stop. They have to take it continuously. Number two, it is very very essential to give the lifestyle modification with that medication. Only if this medication is per se is not useful, or this is not gives rise to best results or desirable results actually. So whatever trial has been done, they are done with the proper lifestyle changes. 500 kilocalories less from the diet and the exercise, and then they have used the medication, they have titrated the medication, and then they got these results actually. Yes, sir. Yes, yes. Yeah, if the see this molecule is already recommended in renal problem. No dose adjustment is required for hepatic patients. No dose adjustment is required for the renal patient number. You can use this molecule in renally failure patient also. The most important thing with this molecule is it causes, as the weight loss will be there, there will be muscle loss as well, and that we don't want that muscle loss actually. Sarcopenia is very very big problem, and in that situation, when the patient achieves 5 to 7% weight loss, we have to give some extra supplementation of protein is very essential. We have to increase the protein content to the tune of 1.5 gram per kg body weight, and along with that, muscle strengthening exercises. Only walking, jogging is not sufficient. At least 3 to 4 sessions of muscle strengthening exercise are very very essential for this type of the patient to maintain the muscle loss, to prevent the sarcopenia. Yes, sir. Yes. Yeah. Yes, sir. There are plenty of links with the obesity and gene preparation, but I can't quote any study that they are doing the gene modification for the prevention of obesity particularly. But as a Indian patients, the epigenetics, our response to the medications, our response to the therapies is different, entirely different as compared to a Western population. So our genetic constitution is entirely different, as I already mentioned. We are more diabetogenic, and we are having more risk of developing hypertension, cardiovascular diseases at lower BMI. They are working on it, but they have not came with some concrete data on that actually. And one more thing I would like to mention, there are some non-responders also. If the molecule is used, there are some patients they don't lose the weight even after those titration with these molecules. So there are no reasons why they are not losing weight. In diabetic patient, the weight loss will be little bit guarded as compared to non-diabetic patients. But these non-responders, it is seen that those patients who are not following proper diet and exercise and not cutting down their calories properly, in those patients we are not getting much results as we are getting results in other patients actually. So it is very essential that we should learn regarding obesity. Every patient we are testing for the blood pressure, blood sugar level, lipid profile. But if the patients are obese, if their BMI is high, get done their Westip ratio, get done their body composition analysis, and now we should have a clear approach for anti-diabetic medication for this type of the patient. Thank you. Thank you very much.
Thank you, sir. I request Dr. C.L. Desar sir to kindly felicitate Dr. Sir. an online question. What is your opinion on dose acceleration in non-diabetic obese?
Same dose.
Same dose is required for the online audience. The question you have asked, sir, is of the opinion that same dose is required. So I request everyone to please keep their cameras on so that we can take attendance. Thank you, everyone. We are done with our attendance. I request to kindly keep your cameras and mic off. Yes, yes. Is it visible online?
So the next presentation is by the most dynamic member of Elite Education and Welfare Society, Dr. Zubair Khazi. He's going to talk about the pharmacological management of the obesity. So we all know that he is working as associate professor in the Department of Pharmacology at MGM Medical College, and he is also member secretary of Institutional Ethics Committee at Icon Hospital. He is involved in many clinical trials. He is one of the dynamic researcher and doing guidance, and I'm not only at IMGM and in Aurangabad also. So I welcome Dr. Zubair Khazi for his talk.
Thank you very much, sir. So, am I audible? Online? Are the slides changing? Am I audible online? Okay. So I'll be taking you to second year MBBS back, as I am a pharmacologist. So we will not be dealing with a very high profile of the drugs. We will start with basics. We will see what are the basic mechanisms, and we will just brush up the knowledge because I already know that you know everything about the drugs that we are going to talk about today. Okay, so as to start with anti-obesity drugs. Yeah. So initially, obesity it was considered to be just a disease of overeating and not doing much exercise. But as we have now developed and evolved in the neurosciences and endocrinology, we now consider obesity as a neurometabolic disease. It is now related as a disease, basically, not just a habit or a lifestyle modification. So these are how obesity develops. It is a chronic and, mind me, relapsing disease. It is not that once you are out of obesity or our patient is out of obesity, will never come back. It is relapsing, and it can relapse at any stage of the life. So it is the dysregulation of appetite and satiety signals to the brain. It is the altered rewarding pathways. There are hormonal and metabolic abnormalities, chronic inflammation, and tendency to weight gain after weight loss. Why all these mechanisms are important? Because we will be just dealing with the drugs depending upon these mechanisms. So once we understand the pathophysiology, it will be very easy for us to remember which drug is acting on which of the mechanism and how it is acting, right? So usually obesity is associated with type 2 diabetes, with hypertension, with dyslipidemias, NFLD, obstructive sleep apneas, and sometimes even malignancies. So modern approach to obesity treatment is now more than just lifestyle modification. Earlier it was just कि अगर आपका वजन बढ़ा है तो खाना कम कर दो, exercise start कर दो. So it was the lifestyle modification, maybe due to delayed in the research in obesity medicines that we will see earlier. But mind me, humans are doing research on medications since 1930 on obesity, and in almost in 2020 or 15 we have got a huge results that actually drugs that are reducing the weight in our patients. So pharmacotherapeutic outcomes that we have seen earlier than 2015 or earlier to the development of the GLP-1 and GIP analogs was just 5 to 10%. That is a very huge result that we used to expect from our patients. But the figure has now changed to 15 to 20%. And as sir has already mentioned, that we are now competing with the bariatric surgeons as for reducing the weight in our patient. So what obesity, what is the mechanism we will see? It is first the increase in calorie intake and decrease in calorie expenditure. It is not that we were wrong earlier. We were absolutely right. But that was not the only mechanism. Okay, there are other mechanisms also involved. So increase in calorie intake and decrease in expenditure. So hence all the speakers up till now have said that there should be a calorie deficit, there should be a calorie deficit, there should be a calorie deficit. 500 kilocalories is said to be deficit in any patient who is willing to or whom we are recommending anti-obesity medications. So first and foremost is a diet plan for our patient. Next, what happens if there is no calorie deficit or there are more calorie intake? So there is excess glucose and fatty acid that are stored into our body. And if beyond the body's capacity, if the fatty acids are there, then there will be no much more storage. There will be hyperplasia and hypertrophy of the adipose cells. Adipocytes, they get hyperplasia and hypertrophy, that leading to increase in leptin, insulin, and ghrelin and adiponectin, all these hormones that are involved in our hunger and satiety. As we all know, just brushing up your knowledge that ghrelin is a hunger hormone and rest all are the satiety hormones depending upon it. अच्छा, अभी आ रही बोली? Jawad sir, okay? Am I now visible? Yeah, thank you. So chronic low-grade inflammation, the hyperplasia, the hypertrophy of all these adipocytes, they lead to a chronic low-grade inflammatory response of the adipocytes that lead to secretion of all the TNF alpha and interleukin 6 and resistin and other inflammatory markers into the body, leading to chronic inflammatory response of the body that lead to insulin insulin resistance, endothelial dysfunctions, and altered lipid metabolism into our body. And that is one of the reason that we call obesity as mother of all the diseases now, because it is leading to all the diseases and all the dysregulations at a very ground level of our body. Okay, then what happens if there is insulin resistance? There will be increase in diabetes, and the vicious cycle will start. The hyperglycemia, insulin resistance, and again there will be hyperglycemia, leptin resistance, and again there will be fat dysregulation, and this will lead to a vicious cycle, and the patient will land up into much more obesity. This was one of the cycle. What other cycle is, just to brush up, is the orexigenic cycle and anorexic cycle. Again, granin, neuropeptide Y, and agouti proteins. These are our hunger hormones, and leptin, insulin, and PPY. These are our satiety hormones, and imbalance between these two leads to it. We are talking about GLP-1 and GIP. So from the physiological point of view, what GLP-1 does is, first it reduces the appetite. It is secreted by the L cells that are there in our intestine, and it reduces the appetite. It slows the gastric emptying. So actually it is reducing the appetite normally in our body when it is secreted, and now we are giving it exogenously. So the mechanism of GLP-1 is it reduces the appetite. The next mechanism will be it slows the gastric emptying time. So if the gastric emptying time is slow, so then there will be a reflex of satiety to the brain, and leading to enhanced glucose dependent insulin secretion, and it suppresses gluconeogenesis from the liver. Then GIP, coming to GIP, it also have the similar actions. It is secreted by the K cells from our intestine, and it again enhance the glucose dependent insulin secretion. It reduces the appetite. It supports the metabolism and storage regulation, and it may or is said to increase the energy expenditure. Okay, so all these with the dual mechanism, if we used agonists on them, then these are the drugs that we will be seeing in fertile. Other hormones that are involved, if all this dysregulation occurs, are cortisol. That we know that if we give more corticosteroids, there is weight gain. So why it is, we now understand it. Estrogen, why there is weight gain is PCOS or PES patients. Now we understand. Adiponectin, resistin, and TNF alpha, growth hormone. Pediatric obesity is usually related to stunted growth. So why there is stunted growth? Because it develops due to chronic inflammatory response. It develops a reduce or resistance to the growth hormone. And now, after understanding all this, our mentality has evolved. We now consider obesity not just a simple view of overeating and less exercise or less physical activity. We now consider it to be having a genetic predisposition, a neurohormonal dysregulation, the environmental factors that are involved, the gut brain signaling access, and altered energy expenditure. So, after considering all these, our targets have changed, and now we target all these mechanisms for developing the new drugs that are there into the market. So in the history, it is, as I have said, since 1930 people are trying to get rid of overweight, and various drugs are being used. So we will start from the history, and just we will see the mechanisms that were involved. First, amphetamine, it was used as an anti-obesity drug. It acted by the mechanism of norepinephrine and dopamine secretion. And as it increased the dopamine secretion, that is a happy hormone, it has got the ADR of dependence. So due to the patient getting dependent on amphetamine, so this drug was then withdrawn from the market. The next drug after a time was, fenfluramine, that was used, and it acts on 5-HT2C receptors. But for reducing weight, 5-HT2 receptors, it was helping. But in as sir will know that 5-HT2 receptors in cardiomyocyte, they are also present and they lead to fibrosis. So there was fibrosis of the walls of our heart, and that leads to material regurgitation and aortic regurgitation. And again, due to this reason, the drug was withdrawn from the market in 1997. So from this, we have learned that whatever drugs we are using for obesity should not act much on dopamine, because there is an abusive potential, and other they should not have any other fibrotic changes into any of the organ because of this. So with this, there are drugs which were approved by FDA. So not going much into the details, I'll just give up the mechanism, and I believe that we will understand what are the side effects and what is being done. So fenphyramine, diethylpropyrrole, benzophentamine, and phenmetrazine. These were the drugs that were initially introduced. They are not used now because we have better drugs, but they are approved for by the FDA for the use in obesity. So if we don't have the options of the recent drugs, so we can still use these drugs. These are not banned. The mechanism by which they were acting is they stimulate the release of norepinephrine to a higher extent and dopamine to a lower extent. Okay, this they inhibit the reuptake of norepinephrine from the cleft that you must be remembering from your physiology, and it again increases the feeling of satiety in our patient. Okay, so there is a feeling of satiety due to presence of norepinephrine and dopamine into the clefts of our patient. And despite of its structures and changes into the chemical, all these drugs, they were acting by the similar mechanism. So this is the mechanism. Now, from the mechanism and our physiology knowledge, we can understand that if any drug is letting norepinephrine to be in your body, it will lead to tachycardia. It will lead to dryness of mouth. As Shanawaz sir has already said that these sympathomimetic drugs need not to be used in our cardiac patients. So it leads to insomnia. It leads to constipation. It leads to tachycardia. So these are the side effects or the adverse effects of these drugs. But still, along with these adverse effects, the risk benefit ratio is better. Hence, they are still into the market and they are using it. Now, one drug which all of us have used, are using, much safer and still available into the market as over the counter drug. It is not need to be prescribed now. It is over the counter that the patient can take it from the medical store and they can use it. So it is that much safe drug. So Orlistat. Okay, Orlistat, it is available into the dose of 60 to 120 milligram. It is to be given with meal, before meal and with meal to the patient. Now it acts by the mechanism of inhibiting, reversibly inhibiting the gastric and pancreatic lipase enzyme. Now this lipase enzyme, it leads to breakdown of triglycerides and then absorption of triglyceride from gut to the body. Okay, so basically we have seen that already there is storage of adipocytes into our body, into our patient's body. We don't want much more adipocyte to be formed, much more fatty acids to be there. So what we do is we stop its absorption, and that is what this drug is doing. That is orlistat. But it will increase the concentration of fat into your GIT or into our patient's GIT. So hence there will be ADR as steroria, oily spotting from the anus, increased flatulence, there will be urgency of defecation, there will be abdominal discomfort. So we can advise our patient not to consume much oily diet while on these drugs to reduce these symptoms. But these symptoms are seen in almost most of the patients, high or low, depending upon the dose that we are using and depending upon the diet that the patient is considering. These were the studies these were the studies that were done on the only stat into the past, and the key buzz that are to be taken. It has got for 2.5 to 3% of the weight reduction. 2.5 to 3% of the weight reduction, and it has got best result with reduced fatty diet. If the fatty diet is reduced, so will get a better result. But the best result that you can commit to your patient, if your patient is on early stat, is 3% as per the evidence that are available to us. Next drug, there are combinations that are available into the market, and these are also approved. Phentermine and topiramate combination is available. Phentermine is again a sympathomimetic agent that it facilitates the release of norepinephrine and reduces the reuptake. And topiramate, it increases the GABA activity. So phentermine, it causes satiety, and topiramate, it also causes satiety, and hence the combination is rational and can be used. But as we have already seen, it is a sympathomimetic agent, and one is GABAergic agent. So GABA leads to drowsiness. It is an inhibitory neurotransmitter. So our patient will have dizziness, will have dysuria, will have some sort of insomnia, and due phentermine will have dry mouth, paresthesia, constipation will be there, and there will be anxiety, and again tachycardia to our patients, leading to all these drugs. They are contraindicated in pregnancy and in patients with comorbid cardiac conditions and comorbid ophthalmic conditions like glaucoma and hyperthyroidism. These were the trials that was conducted on phentermine and topiramate combinations, that Concord trials, Equip trials, Scale, Gate, and these all the trials, and still the trials are continuing in 2020. The last trial was published in 2020, and the key take notes is you can use only for the chronic weight management. So if we are using the drugs like GLP-1 analogs, and then you want to take to chronic weight management, so this can also be one of the option. Depending upon, there are no guidelines. This is just a pharmacological view that I am proposing. Next is naltrexone and bupropion combination that is available. So naltrexone, as we all know, is an opioid antagonist. So it blocks the opioid receptor and hence it decreases food rewarding phenomenon and decreases the craving of the food. And bupropion, it inhibits the reuptake of norepinephrine and dopamine again, and leading to increase in satiety and increase in energy expenditure. So these are the adverse effects that we see: nausea, vomiting with naltrexone, constipation, and dizziness. Seizures are seen with bupropion, and these are the warnings in which we cannot use. It may increase heart rate, it may increase blood pressure. So again, cannot be used in cardiac patients. We need to monitor the depression and suicidal ideations in such using naltrexone and bupropion combination. So a very hot and burning topic of suicidal tendencies in people who are using anti-obesity drugs. So this is the first time that we are uttering about the suicidal tendencies in. So why? Because of the phenomenon that we see here. One of the mechanism is decrease in rewarding pathways that is there when we eat food. When we eat food, there is a rewarding pathway that gets activated. There is secretion of dopamine, there is secretion of serotonin in our body, and with due course of time, when that rewarding is reduced, the patient may feel depressed, and depression may lead to increase in suicidal ideations. There are risk of seizures with these agents. Now coming to These are the trials, the core trial 1, core 2, core 1 trial, core diabetes trial, and in 2023, a light trial on cardiovascular outcomes of this combination was done. Now, coming to the very important molecules that are there, first one is the liraglutide. It is available in 3 milligram, and we will see its mechanism. It acts by as a GLP-1 analog. It acts on agonist, and it acts on GLP-1 receptors. And as we have already seen how GLP-1 is physiologically acting, it increases the glucose dependent insulin secretion, it decreases the inappropriate glucagon secretion, it reduces the gastric emptying time. All these will be seen when we are using agonist of these receptors, and liraglutide is one of the agonists. Here I will focus on how to administer. Liraglutide is administered subcutaneously. The T half is 8 to 12 hours, that is there, and 55% bioavailability is there. It is given once a daily dose only. Okay, subcutaneously, once a daily dose, and it reduces the appetite and food intake. It increases satiety. It reduces the body weight and improves the glycemic control. Nausea, diarrhea, constipation, vomiting, and headache. These are the common adverse effects that we will be seeing with the GLP-1 and GIP analogs. And these are so common that due to nausea, your patient may feel to discontinue from the treatment. And I have 2 to 3 patients who cannot tolerate nausea even at the lower dose itself. So it is not that if we are having newer drugs, the older approved drugs can be rejected. So indication is again BMI of more than 30 is obese, or more than 27 and overweight. We see if your patient is having hypertension, dyslipidemia, and type 2 diabetes, or obstructive sleep apnea. So that is the two indication to start with liraglutide. The dose, as we have already discussed, we start with the minimum dose of the drugs so that your patient get acclimatized to the nausea, your patient get acclimatized to the constipation and other. 0.6 milligram we start with OD, and then we titre the dose. And the warning signs are obviously, as answer has already said, that pregnancy is a contraindication for all these drugs. You have to give a washout period of 5 half-life. So half-life for this drug is 8 to 12 hours. So we will have to stop the drug at least a month before if your patient want to get pregnant. And why we are so much concerned of pregnancy? Because PCOS patient with weight gain coming to you with weight loss, the primary aim to get pregnant. So we have to consider that when to stop the drug. Do we achieved the target, and does our patient safely go to pregnancy now? So scale are the trials that were done on liraglutide. Scale obesity, scale diabetes, scale sleep apnea, and all these are the trials that are done on liraglutide. Coming to semaglutide. Semaglutide is again it is a glucagon like polypeptide, that is GLP-1 receptor antagonist, and it is 94% homologous to the physiological GLP-1 that is there. Hence it has got such a good response from our body. It is also administered subcutaneously. Once a week injection is given with the bioavailability of 89% and half-life of 1 to 3 days. With the T max is 1 to 3 days, and half life is for 7 days. And again, it reduces the appetite intake, increases the satiety, and the common adverse effects are again nausea, diarrhea, vomiting, and constipation that we see. These are the indications. And dose administration, we start semaglutide with a minimum dose of 0.25. Though your patient is very enthusiastic, we have available injections. It is now available just at the cost of 1500 rupees for a month. but still we start with 0.25 for at least a month. That is to be recommended, so that your patient get used to the nausea. And the key rule for starting all this is, this is just the training period for your patient. You are just supporting your patient by suppressing the appetite, by increasing the satiety, and a training period is to be given, so that any food cravings, any rewarding habits, any punching, not doing exercise. So anytime we have to motivate our patients for doing all this during this drug period time. You have started with semaglutide 0.25. You have to send your patient to gym. You have to give a diet plan. You have to produce a calorie deficit, and along with that, you will see very better results on your patient with this. And then we start titrating or accelerating the dose to 0.25, and we go to 2.5 milligram of semaglutide, 2.4 milligram of semaglutide, and the maintenance dose of 2.4 milligram, that is given once a weekly, is to be maintained in our patient. A very predominant ADR seen is nausea again with this, and diarrhea, uncontrolled diarrhea, but it is not at all infective. So we can use anti-diarrheal drugs in these patients to reduce the diarrhea. Nausea, for covering the nausea, it is recommended that you start with the PPIs beforehand starting with the treatment. Suppose you are about to give injection to your patient tomorrow, to 3 days prior at least you should start with, 2 days prior you should start with proton pump inhibitors, and then you introduce the injection to reduce the symptoms of nausea. Medullary carcinoma thyroid is something that was much more discussed, and risk of pancreatitis was discussed with this. Definitely there are ADRs of medullary carcinoma thyroid and pancreatitis with these molecules, but they are not very common. They are rare, and suicidal tendencies are there with these molecule. But why? We have already seen the mechanism. STEP is the trials that were conducted on semaglutide, step 1, 2, 3, 4, and select trial is was going on, and in 2023, and we are waiting for the results. Now coming to the very much discussed from morning up till now, all the speakers have talked about tirzepatide. I am taking the molecule a bit fast because we have to come in time. Tirzepatide, it is different from semaglutide. It is on GIP and GLP-1 both. The mechanisms are similar: increase in glucose dependent insulin secretion, decrease in glucagon, increase in adiponectin, and decrease in hepatic gluconeogenesis. And the bioavailability is 80%, and the half-life is for 5 days. The dose is to be given once a week. The dose, it starts from a 2.5 milligram for tirzepatide, and we accelerate it with 2.5, then 5, 7.5, 10. Maybe your patient is of 167 kgs. You have to start with 2.5 only. On 2.5, maybe you don't see much of the weight loss. There will be 1 to 2 kgs in a month weight loss, but that is just the priming phase for your patient, so that your patient get used to nausea and diarrhea. It reduces the appetite, it increases the satiety, and it reduces the body weight. So tirzepatide, as we have already seen, acts on GIP and GLP, and it is called as the dual incretin agonist. Indications are chronic weight management, BMI more than 30, with only obesity, and BMI more than 27, along with other comorbidities. And dose, as we have already discussed, is given subcutaneously. A pre-filled injections are available with 2.5 milligram, 5 milligram, 7.5, 10, 12.5, and 15 milligram. The dose is to be maintained for the patient if you achieve the desired target weight. And as I have already said, that this is just a training period. The drug period is a training period. If your patient is maintaining weight on a particular dose, suppose 7.5, you continue with 7.5. If when you accelerate the dose, okay, your patient will start having cravings, start feeling hungry after 3 to 4 days of giving injection. So when your patient, you have to take the history of your patient, whether you are feeling hungry in 3 to 4 days after taking the injection. Suppose the injection is taken on Monday, so on Wednesday, Thursday, your patient will again have cravings, again will feel hungry. There will be reduction in nausea. So that is the sign that you have to now increase the dose. So we have to increase the dose from 2.5 to 5, obviously, but this I am talking about maintenance dose. If you have, your patient is on 10 milligram and now feeling hungry and the cravings have came back again, so this is the time that you have to increase the dose. So surmounts are the trials that were going on with the tirzepatide 1, 2, 3, 4, 5. These are the trials that tirzepatide were. A newer molecule that is under research is set melanotype with a mechanism bit different. It acts as agonists on melanocortin 4 receptors, and it mimics the alpha melanocyte stimulating hormone, that is alpha MSH, to activate, and it reduces the appetite, again increases the satiety, increases the energy expenditure, and reduces the body weight. So as it is acting as a melanocyte agonist, one of the drawback or one of the ADR will be darkening of skin. Okay, we now understand this from our physiology. So darkening of the skin will be there. The nausea, headache, skin darkening are the ADRs with this drug. The starting dose is again 2.5 milligram, that is given once daily, and we can titre it weekly, and maintenance dose is 2.5 to 15 milligram once daily, that is to be given. The POMS is the trial that is going on for these drugs. Now coming to the drugs that are off-label used, we all know metformin. Since long we are using in PCOS patients. Since long we know that it has a role in reduction in weight also, but it is very to a very less extent. And all these are the drugs. Time does not permit. I'll just mention here the SGLT2 inhibitors. SGLT2 inhibitors are profoundly seen with reducing the weight. They cause glucoseuria, and dapagliflozin, empagliflozin at the dose that we are routinely using in diabetic patients, it has caused a reduction in 3 to 4 kgs of the weight over the period of time. And the important point is it reduces the visceral fat. So as Ehsan sir has already said that by the BCA machine we can calculate the fat percentage of our patient. So it is much more beneficial if it is reducing visceral fat, and so that the SGLT2 inhibitors do. The emerging drugs. So why? What was the importance that everyone is studying obesity suddenly since last 1 to 1.5 year? We are organizing conferences and we are talking about sarcopenia, is because there is a flood of drugs that will be coming in this or maybe in next years. Many of the clinical trials are going on. The one who has almost completed the clinical trial is retatrutide. It is the molecule of Eli Lilly with the multiple agonist of GLP-1, GIP, and glucagon, already discussed by Dr. Ehsan sir. It is into the phase 3 trial, and it is expected to get approval this year, but maybe in next year. Then CagriSema is another by Novo Nordisk. It is a combination of cagriglutide and semaglutide. So this combination is again is into the studies phase 3 and may get approval. Then cagrelintide is again, and this is the combination, this is again by the Eli Lilly company, and amylin analog is under phase 2 and phase 3 of the clinical trials, and maybe till 2028, if everything goes well, we will see this molecule on the surface. Then orforglipron is again by Eli Lilly. It is an oral non-peptide GLP-1 analog that will be seen. Phase 3 is ongoing. Potentially will get in 1 to 2 years. And amycretin, we are listening about amycretin since 10 to 12 years that this will come into the picture, but still it comes into the drugs that is under trial. Then maritide is a drug, then mazutide, then survodutide and pemvidutide. These are again the drugs that are into the study. Amylin analogs, GLP-1, analogs. These are the mechanisms on which researchers are working for obesity. All these drugs are in phase 2 clinical trials and maybe get approved if everything goes well in 2028 or 29. So this was all from my side regarding the pharmacology. I am ready for questions if any, or else we will continue.
I will take the question from lunch hour. During lunch hour, we'll take the question. I request Dr. Sardar Pathan and Dr. Tariq sir to felicitate the speaker.
So our next speaker is Dr. Badar Daimi sir. He is professor and head in Department of Physiology, and he has completed his certificate course in evidence-based diabetes mellitus. Is a resource faculty for the faculty development program that is recommended by NMC. Sir is a student of physiology, passionate about teaching, and inspires as a mentor for future doctors, and now a student of mindfulness, and he embraces it. So he has deliberately written student because he consider himself as a lifelong learner, and so we all should. So I hand over the mic to Dr. Badar sir. Is it visible online? Okay. John, sir, is it visible? Comfortable?
Bismillahirrahmanirrahim. Assalamu alaikum and good afternoon, one and all. So, at the very outset, I would like to thank Almighty Allah for giving me opportunity to come over here and speak. Also, the team elite, and last but not the least, Dr. Saeed Siddiqui sir, because due to some unavoidable circumstances, he was not available for his talk. So, it was handed over to me. So, there's a famous quote you all know: watch your thoughts, they become your words. Watch your words, they become your actions. Watch your actions, they become your habits. Watch your habits, they become your character. And the character is one which becomes your destiny. So I'm going to deliver a talk on role of mindfulness in obesity management. So somebody talked to me about that. There are various sessions going on: pharmacotherapy of managing obesity, surgical treatment of obesity, and many more things. So injectables, orals, all those things. But somebody said me, sir, तुम सबके किए कराए पर पानी भरने वाले. You are talking about mindfulness, how mindful eating is going to control obesity. So it's not like that. So acknowledging Dr. Said Siddiqui sir, because most of the slides are from his presentation. So learning objectives for today's talk is definition of mindfulness, mindful eating, and what mindfulness-based interventions are, which are applied for obesity care. Also, I'm going to explain the psychological and behavioral mechanism by which mindfulness may influence weight-related outcomes, and apply findings to inform multidisciplinary real-world obesity management. We all know the epidemiology about obesity. Many of our speakers have talked about. So it's almost 160 million children and adolescents living in overweight or obesity worldwide. And weight loss is a multi-million or multi-billion dollar industry, 3 trillion per year. And they attract their customers, rather their patients, by giving some catchy alphabets or catchy posters. Imagine in a center where it is written, कभी कभी जीतने वालों कभी कभी जीतने के लिए कुछ हारना पड़ता है, और हार के जीतने वाले को बाजीगर कहते हैं. So they are giving a tag of बाजीगर to everyone who is losing weight, and somewhere it is written losing is winning. You're losing weight and you are winning. But what things are important in losing weight, apart from pharmacotherapy, apart from surgery, apart from many things which are talked about, that the conventional weight management therapy, which includes the calorie restriction, the exercise, pharmacotherapy, and surgery, they won't last permanent. But one thing which can make it happen for long time is mindfulness. So what is mindfulness? So there is limitation for conventional obesity management strategies. For example, high attrition rates because dropouts. Any treatment patient is getting, they may get dropout of the treatment plan and the obesity relapses. Weight regain, lifestyle only interventions frequently show poor long-term maintenance with high rates of relapse. And also under address psychology. So there is a psychology we need to tackle for treating obesity. So stress, mood disorders, eating disorders, dysfunctional eating pattern, which includes emotional eating, binge eating, or external eating cues. Poor drivers are the co-drivers for weight gain, yet are often left untreated by diet, exercise, and pharmacotherapy programs alone. So why this is important? Because psychology matters. Mood disorders or eating disorders are one of the most important independent risk factor for development of obesity. So we are going to tackle that thing. So it's a role of psychologists, psychiatrists, certified mindful trainers, which comes into picture for the management of obesity. Just take a recap of what you had in your dinner. Can you imagine yourself what you had in your dinner? What things were there? Yes? Sir? Dal chawal. So, how many servings of dal you took or how many servings of chawal? Chawal, bagare chawal थे या steam rice था या फिर और दूसरा rice था, right? उसमें तड़का था या नहीं था? And at last, did you express gratitude to the person who prepared? So this is all about mindfulness. अगर हम ये सब करते हैं while we are having our food, so that gives a good response to our body and also to the physiology behind our weight. So definition of mindfulness. So I'm not going in detail of definition because it will be like कहना क्या चाहते हो. So I asked to my one of my senior, what is mindfulness? So he described mindfulness as doing something with khushu and khuzu. Okay, mindfulness. It should be non-judgmental awareness of one's emotional and physical well-being and also with the surrounding and being present from the start of the movement to the end of the movement. So that is mindfulness. And the basis of mindfulness is that you are what you are what you're eating, you are what you're talking, you are what you're walking. So, mindful eating is one such application of eating experiences, attentively focusing on physical, mental, and emotional aspect of eating. Yes, we have physical need, we have emotional need, and also we have sometimes mental need for eating. You must have seen we had our breakfast in the morning, but tea and coffee was served over here, so we had tea and coffee. While sometimes we already have stomach full of our meal, but our friend calls for chai, chai pe charcha, and then we again have chai and chaska maska and everything with that thing. So that is away from the mindful eating. So I'll just express you one incident that Mr. Chishti sir is from Parvani. So many of his students are faculties at our college at Badnapur. So he came over here. So everyone was expressing gratitude. Everyone was feeling happy that our teacher is over here. So everyone was trying to please him. So chai lo, pani lo, biscuit लाएंगे, ये लाएंगे. He said no, 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 no. Finally, sir ने बोला acidity होता है. So we asked for that Amul milk. So we handed over to him. He took that Amul milk. We had a conversation of almost 45 minutes. And at the end, he just put that Amul milk bottle in front of the table and said, thank you. He never drank it. He said, I have accepted it, but give it to someone else. So that is mindfulness, whether it is required emotionally, physically, mentally, what we are eating. And here, as an adjunct to whatever the treatment has been spoken about just now. So mindfulness based interventions are there which acts as an adjunct for obesity management. So what is mindfulness? Particularly deliberately paying attention. Yes, we should deliberately pay attention. Most of our eating or habits are going on autopilot mode. If I ask you which vehicle you have parked next to your vehicle, which vehicle is parked next to your vehicle. You might be noting red color car, blue color car. But if I asked you where did you park yesterday in your nearby your clinics, you won't remember because everything goes on autopilot mode. We are eating on autopilot mode. We don't think kya kha rahe hain, kitna kha rahe hain. So mindfulness is what we are eating, why we are eating, how we are eating. So that all is included in mindfulness. So focusing on present moment. अभी ये खा रहे हैं हम लोग. Like in my introduction, I have written I'm a student of mindfulness now because 3 days back I was not aware of this concept. And today itself, I was preparing for my presentation and then breakfast came in front of me. And I thought कि मैं वो prepare करूँ क्या ये करूँ. So laptop खोल के बैठेंगे हम. I thought of myself, no, I should be mindful. I kept aside my laptop. I had a good breakfast. I thanked my wife and came home. And I'm relaxed now. So presenting in that particular moment, that is mindfulness. Awareness without criticism and judgment. What's going to get in future, what has happened in past, that should be away from that moment. Experiencing the sensation and thoughts that come up us as we eat. So what sensation do you feel when you eat? So that is again a mindfulness. So it promotes balance, choice, wisdom, and acceptance what it is. So there is mindless eating also. So we start eating mindlessly in large quantities and very quickly. 20 मिनट में खत्म करना है काम. एक थेरेपिस्ट ने बोला था कि योर मील शुड लास्ट फॉर 20 मिनट्स. सो पर्सन टुक इट एज आई हैव गॉट 20 मिनट्स विंडो. I can eat anything in that 20 minutes. But the psychologists want to say that eat slowly, have 10, 20 minutes for your meal because for the signals receiving for fullness, satiety, signals from stomach to brain goes in 20 minutes. But before that, if we eat like anything, a lot of things in short time, 10 मिनट में खाना खत्म हो गया, अभी सिग्नल पहुंचा ही नहीं satiety तक, brain को. So 20 minutes is the time span where the body gets aware that you are now satiety. We miss about the taste, texture, enjoyment of eating. So eating should be pleasurable experience, ideally with time and nice setting devoted only for food or meals. So mindful eating is eating with awareness, being connected to your senses, being aware of food, taste, texture, knowing when your body is hungry and when you have had enough. खाना खा लिया लेकिन फिर से दूसरी बार बैठते हैं हम लोग. So that should be avoided. Listening to what your body wants to eat, letting go of worries, and being in the moment. That is most important. So benefits of mindful eating are eating less food. So if you are mindful in eating, you will definitely eat less with whatever is required. So I am full message you will get very early. You will be satisfied. May lose weight in long run. And also feeling satisfied, no judgment or negative feelings will be there, and ability to enjoy your food in moderate portion will be the most appropriate thing which is happening. So better digestion, it also helps in better digestion, and most important, you will enjoy what you are eating. Now, core principles, components, and delivery formats for mindfulness based intervention. Number one is called as MBSR because one of the most important factor which leads to eating disorder is stress. So it is mindfulness based stress reduction, MBSR, which has to be incorporated in the format of CBT, cognitive behavior therapy, that is called as MBCT. And then adding this MBCT in your eating awareness training. So that has to be trained to each and individual patients. Now, I would like to take some time over here to explain that most of the physicians are not giving appropriate time for the patients, in particularly treatment of diabetes, obese management. What is happening? We are more focused on prescribing drugs or suggesting exercise, and most of the physician will have the diet chart on back of their file. But whether it is tailorized, whether it is applicable to that particular person, we have to spend some time. If you can't spend time on giving for the patients, you have to have one counselor, you have to have one dietitian or a certified mindfulness trainer. That is must in every diabetes and obesity center. That is what I feel, and many of the systematic trials have also suggested that. So theoretical framework linking mindfulness to weight regulation is that self-regulation theory is there. because dietary and physical activity adherence depend on sustained self-monitoring and inhibitory control. So if you are just having calorie count and just having exercise, but it has to be self-monitored on regular interval. So mindfulness training strengthens attention, self-regulation, the capacity believed to underlie healthier eating choices. That is important. Decentering is also important because we are always having our eating pattern which are not influenced by our hunger but also by our emotional eating. We are more towards emotional eating. So what it does, it increases the ability to resist desired but unwanted foods and countering the mindless type of eating. So mechanism, how does it affect mindfulness? Number one mechanism is stress reduction, emotional regulation, and HPA axis effect that has been proved in a meta-analysis that I'm going to discuss in just a minute. Another is introspective awareness, appetite regulation, and reward pathways. And because this is very important. So what we are eating, that we should know. If we are not mindful in that particular state, we eat anything. Like what is required for us, whether it is required, whether we are eating because we need it or we are eating just want to eat. Like coming back from your work, there is a chips packet, we have ate it, and then we are finding it, finding guilty that I have had all full packet of that chips. Instead, you can have few chips in the plate and can have it. So that is again a part where introspective awareness is required. So emotional eating is one thing where eating when you are not hungry particularly. चलो सामने आ गया तो खा लेंगे, फ्रेंड्स ने बोल दिया तो कर लेंगे. So using food as a reward, mostly we do it. Okay, आज कुछ हो गया तो चलो reward, पार्टी करते हैं, right? So eating to avoid dealing with stressful situation. This is again a very important part of the eating disorders. Eating when you are depressed or discouraged, particularly eating when you are frustrated or unfulfilled, eating to fill emptiness, khali बैठे हैं, चलो कुछ खा लेते हैं. Eating when you feel anxious and ignoring your natural hunger and fullness signals. What are the triggers which lead to emotional type of eating? Is food characteristics, activities. कुछ कर लिए हम लोग गए प्ले एक्टिविटी करने के, लेकिन उसके बाद अपना खाना खाने पे खत्म होता है. कोई भी एक्टिविटी करने के हम लोग वी एंड इट विद सम टाइप ऑफ पार्टी और फूड. इवेंट्स, कोई भी इवेंट में जाएंगे हम लोग घर पे खाना खाएंगे, यहाँ पे भी खाना खा रहे. फाइनेंशियल प्रेशर आता है, we get frustrated, we have meals. Fatigue, work stress, and time and weather, these all are affecting our eating habits. So emotional hunger is where it comes suddenly, एकदम से भूख लग गई. क्रेविंग स्पेसिफिक फूड, जैसे बोलते हैं भाई कहीं कहीं गए, हमारे दोस्त लोग बोलते हैं भाई ठीक है बाकी सब बाद में लो, पहले बिरयानी ला लो फिर बाद में बाकी ले. So they crave some particular type of food. There is instant gratification. There is obviously going to have overeating and there is guilt feeling. Whereas the physical hunger is where it develops gradually. दे आर ओपन टू ऑप्शन, जो मिलता है वो खाएंगे या फिर जो पसंद नहीं है वो भी खा लेंगे जब हम हंग्री होते हैं. वी कैन वेट, इट विल ग्रेजुअली डेवलप एंड इट विल स्टॉप व्हेन वी आर फुल एंड व्हेन वी आर satisfied. That is difference between emotional hunger and physical hunger. So there is a scale of fullness we should follow. The scale 0 is empty, you are feeling dizzy, you are feeling like you are going to fall off, you are going to get dose off. So that is 0. 1 is ravenous. Around 3 is hunger pangs. 4 is hunger is awakens. 5 is neutral. 6 is just satisfied. 7 is completely satisfied. Then 8 is full, stuffed, and sick. So that is a hunger fullness scale. So we should put ourselves in the range of 4 to 7. If you feel more hungry, it is more natural that we are going to go into overeating. So before getting into the stage 2, 3, over hungry and all those things, we need to have our appetite in between 4 to 7. 7 is completely satisfied. But even though after completely satisfaction is again not a, we cannot scale it properly. So our scale should be in between 4 to 7. So when you start feeling like you want to have something to eat, rate your hunger on the scale of 1 to 10, and then you have to, 1 is hungry, starving, and 10 is being full. So 5 to 6 or 4 to 7 is mostly widely accepted. So mechanism, Number one mechanism is reduction of emotional, external, and binge eating type. So this has been suggested by this review. These reviews are taken from Q1 journals. So here the narrative reviews of self-help strategies in obesity treatment focused on hypnosis and mindfulness as adjunct or alternatives to cognitive behavior therapy. So here there are 6 prior meta-analysis which has been studied, 16 recent RCTs, and some MBSR, that is mindfulness-based stress reduction techniques. So they synthesizes prior systematic reviews, almost more than 16, and they have the findings are that moderate effect is seen in weight loss across prior meta-analysis of mindfulness-based intervention. So wherever there is mindfulness-based intervention, what is this mindfulness-based intervention? We teach them how to be mindful. So for example, in one of the study, they have divided the group into 3: eat group, mind group, and slow group. So they have given 2 meals everything. The first group, the eat group, they have to take their meal first. There is no intervention, and then they are giving after morning and then evening second meal. The slow is first they will eat their meal normally. Then the intervention is given that we teach them to eat slowly, and then the second meal is served after some time, and they have to implement that intervention. They have to eat slowly. And the third group is mind group. So they will eat their meal first. Then there is a training of mindfulness, how to have mindful eating, and then the second meal was served. So in this type of eating, it has been found that this moderate effect is seen in them about their eating habits. So that is very important. So the G value of 0.42 to 0.47 is given, that shows moderate effect in weight loss. G effect for moderate to large effect on obesity related eating disorders is 0.7 to 1.8, and G value for large effects specifically on binge eating. So those person who are having this binge eating or eating disorders, emotional eating, so those have shown the very moderate to large effect seen in this meta-analysis. The second review is by Carrier, which is published in 2018. So again, it's a systematic review which have taken into consideration 18 publications. Here, the G value is 0.4. The G value is where we are going to consider in meta-analysis. Multiple studies are there with diverse intervention with different sample size. So G value is 0.4 and above is good. It is showing some effect. Less than zero point 0.2 is having negligible effect. So most of these things at 0.7 G in obesity related eating disorder behavior, which is an improved 0.5 to 0.4 weight loss with combined formal informal practice is seen. And lastly, the G value of 6.8, which is large effect seen where there is weight loss seen in this person. And most important is that this participants were followed up for span of 5 to 10 years. So again, they maintain their sustained loss in weight for long time. So again, this is not just MBIs, mindfulness based intervention. They are acting adjunct to whatever therapy they are taking. So in consensus, if we see, these 3 meta-analysis has been suggesting. So most of them showing the design, most of them showing the G value is very good, moderate to large effect in weight and anthropometric effect, and also in eating disorders. So what they suggest is moderators that help include combined formal and informal meditation practice should be advised or recommended. Second, delivery in clinical settings. So the studies which are done in clinical settings, they showed better response in terms of the G value, which is more than 0.8. And combining MBIs with standard diet, exercise, and CBT rather than using mindfulness alone. So mindfulness alone is not going to bring back obesity to normal, though it will affect in preventing obesity. But the treatment should be in adjunct to dietary and the pharmacotherapy. Sustainability, like you can see in some of the studies, long-term effect is seen for more than 6 to 12 months. Follow-up data remains sparse across 3 reviews. That is with only mindfulness. But in adjunct to other treatment, the data suggests that the obesity has been controlled, or the BMI was reduced for sustained time of 5 to 10 years. And there are psychological benefits to it: moderate reduction in depression and anxiety, improves self-acceptance, body image, and quality of life reported across. Finally, practical implications of what mindfulness will do in obesity care. We have to position it as an adjunct, not a substitute. Mindfulness eating. Second, combine formal and informal practice. Formal practice, what we get in a clinical settings. Informal, we can have what we can say Sunday walk for our group, so that we can take the group to Himayat Bagh or somewhere else, and then we can practice and teach them mindfulness. Or we can also match delivery setting to the target behavior. Someone is very busy, we have to take time for them, and we have to arrange mindfulness, mindless. We have to implement mindfulness in them by giving separate session. One-on-one sessions are more better, and building treatment fidelity monitoring. That like we have to tailor made. It should be tailor made. It should not. It should be individualized. And finally, the key takeaways are the mindfulness based intervention show small to moderate consistent benefits for weight and obesity related eating behaviors. They also benefit are strongest for mindless, cue driven eating, more modest, and context dependent for stress driven and binge emotional eating. That is, benefits are very small in mindless eaters, but somebody who is having eating disorders, the benefits are large. So, combining mindfulness with standard dietary, exercise, and behavioral therapy along with pharmacotherapy, rather than using it alone, that will have consistently yields the largest effects. And long-term maintenance, treatment fidelity, and integration with modern pharmacotherapy remain priority areas for future research. So these are the three references which I have got. So whatever we are here, we are planning to do. If you are going into mindfulness, so the best time for me to plant a tree was 20 years ago, but the best time is now. So I am I have started being mindful in many of the things. Thank you very much. If you have questions, yeah. I'm surprised, sir. Yes, very mindful in attending the meeting.
With this, I request Dr. Altaf sir, as he is here, Altaf Kurish sir, to kindly facilitate our speaker. Sir. And as we are learning about mindfulness, so we are just now having only awareness of hunger because two talks are still there. I request the speakers to kindly let us be in that freedom. So with this, I call upon our next speaker, a very dynamic and handsome Dr. Zakir Momin sir. He is a plastic surgeon. He is a consultant at Icon Hospital and SBS. And to mention here, he has successfully done the finger replantation and thumb replantation and many other during his career up till now. So I hand over mic to sir with a request to kindly take the session a bit fast.
So finger implants, hand implants.
एक लेता मैं आपको पूरा सेट करके देता Jawad sir, online, is it the slides are changing? No? Okay. What?
Uh, Good afternoon, everyone. First of all, I would like to thank the organizers for giving me an opportunity to speak on this topic. And after all the talks that we have heard since morning about regarding obesity, we have heard about massive weight loss, how to achieve weight loss in obese patients. Mainly, we have heard about pharmacotherapy. We have also heard from about mindful eating from Badar Daimi sir. What we have missed today is bariatric surgeries. It would have been better if we would have included a few topics on bariatric surgery as well. What I will be covering mainly is what happens after massive weight loss, because we have focused on weight loss, but after weight loss, what are the functional complications that the patients are facing? What day to day, what problems they are facing in their day to day life, and whatever pictures today I am going to show are being shown after taking all the required consents from the patient. So, moving forward, what is obesity? Obesity is excess fat accumulation and constitutes major risk factor for cardiovascular risk, type 2 diabetes, sleep apnea, and joint degradation. But and the skin reality. The chronic obesity stretches the skin collagen and elastin fibers beyond their point of snapback. What is snapback? So that I will cover in the further slides with a balloon analogy. Just to cover in short, if you consider a rubber band, if you stretch it to its extent and if you release it, it originally snaps back to its original position. The same does not happen with a balloon. I will just show you with an example. Now, what are the obesity management strategies? These we have covered since morning: the pharmacological therapy, GLP-1 agonists like semaglutide, nutritional counseling, and behavioral therapy. Bariatric surgeries, which include gastric bypass, sleeve gastrectomy, and duodenal switch surgeries. Now, moving from the metabolic health to the physical comfort, that is what covering the functional problems of the patients after massive weight loss. So, uh, obesity, sorry, massive weight loss. The paradox: patient loses the weight but are left with the hanging reminder that are the folds of the redundant skin. So this is the patient after massive weight loss. So the problems that these patients face in their day-to-day life include hygiene issues, back pain, intertrigo, and difficulty with clothing and daily activities. And also some skin issues like skin loss of skin laxity, poor skin quality, and excess skin everywhere. There is a psychological impact with such as body dysmorphia and a sense of incompleteness despite health gains. So the balloon analogy that I was talking about, if the balloon is kept inflated for an extended period of time, when it is deflated, it will not go back to the original size. It will get smaller, but at a certain point, it will not contract anymore and will start to wrinkle. It will also have permanent change in its intrinsic elasticity. This is what happens to the skin fat envelope after massive weight loss. So once a balloon is inflated and kept inflated for some time, and after that, once it is deflated, it is never going to go back to its original size. Same happens with our skin. It will be redundant and it will be loose from all sides. So After body contouring or cosmetic procedures for to do body contouring, this it will not revitalize the skin or the fat envelope, but it will contour the skin to a better shape. So there are different management strategies in body contouring after massive weight loss. So non-surgical management and surgical management. Non-surgical management per se does not have a extensive role after massive weight loss. It has a very limited role, and main focus will be on surgical management. The non-surgical management includes cryolipolysis like fat freezing, but it is best for stubborn pockets of fat and for skin tightening. Radio frequency and ultrasound stimulates collagen to provide mild skin retraction. Injectable fillers for volume and minor skin quality improvement, just to provide some sort of facelift or hollowness in the face after massive weight loss. The bottom line, non-surgical methods are rarely sufficient for massive weight loss patients with significant skin laxity. Surgical management, it includes principles of surgical management is the 360-degree approach, thinking of a body as a cylinder and not as a fat plate. Staged procedures often require multiple surgeries. We target the core first and then move on to the extremities. And key goals of surgical management includes removing the redundant skin, tighten the underlying fascia, and address residual localized lipodystrophy or fat. So, what are the pros and cons of body contouring? The pros obviously includes improved self-esteem, improved hygiene, improved activity, and better clothes fitting. And cons, as with any surgeries, they will leave scars, downtime of surgery or recovery time, complications of surgery, wound healing issues, seroma or hematoma formation, and infections. So, what are the considerations we need to take during a body contouring surgery? So, importance of weight maintenance, stable and body mass index of less than 30. Importance of nutrition, correction of common nutritional deficiencies, LFT, albumin, pre-albumin, optimization of protein, optimization of nutrition of the patient, and evaluation for risk of DVT and pulmonary embolism. Preoperative evaluation and body contouring surgery is the body habitus or fat deposition patterns, morphology of skin redundancy, degree of skin deflation, body mass index at presentation, quality of skin envelope, and position of scar placement. Scars obviously will be left after a body contouring surgery, but we have to place them strategically so that they are not obviously visible. Safe body contouring surgery includes duration should be around 5 to 6 hours. We should not extend a surgery to too long, of 10 to 12 hours. No extreme makeovers should be done. Stage procedures should be focused on first stage abdomen or body lift, second stage extremity breast, lateral chest revisions, third stage thigh and arm revisions, and fourth stage facelift has to be performed. So, surgical goals in upper body procedures to reshape or augment breast parenchyma to restore projection and fullness, to achieve appropriate nipple areola complex position and size, to recreate or reposit the inframammary fold, to reduce the skin envelope, and to eliminate prominent axillary skin rolls. In lower body procedures, mainly focus on flattening the abdomen, recreating the umbilicus, elevating the mons pubis, creating waist in female patients, excision or liposuction of lower back roll, defining the buttocks, and improving inner thighs. So these are the different body contouring procedures that can be done. Face and neck lift, upper body, as I have already enumerated. The lower body also has been enumerated previously. So the most commonly procedure that we all know about is liposuction. Liposuction after massive weight loss has a limited role because mainly the body contouring surgeries will come in. Liposuction per se does not have a very major role. Liposuction is surgical aspiration of subcutaneous fat by cannula attached to a vacuum pump. Okay. It is based on the principle that the number of adipocytes that are present in the body are constant, that are not going to increase further. So basic science and scientific considerations in liposuction includes the above fat plane is divided into superficial, intermediate, and deep fat planes. Safe liposuction is mainly performed in the intermediate and deep fat planes. We do not touch the superficial fat plane because the vascularity of the skin is being carried in the superficial fat plane. If the superficial fat plane is disturbed, then we see the complications of skin necrosis and wound healing complications. It is the intermediate and deep fat planes that will lead to a safe liposuction. Now, there are some zones of adherence that are present, and zones of adherence are dense attachments of the underlying deep fascia to the overlying skin. So, in these zones of adherence, we have to avoid liposuction so that the natural shape and curve of the body is not disturbed. Patient selection is also important. A successful liposuction patient must satisfy four elements, that is, lifestyle changes, regular exercise, balanced diet, and a stable weight. So this is examination of a patient who is undergoing lipoabdominoplasty for to see for the any herniation or weakness in the abdominal muscles. In that case, liposuction cannot be if that is there. If when ventral hernia is present to the patient, the ventral hernia has to be repaired first before a liposuction is performed. Preoperating markings, not going into the detail as we are short on time and everyone is waiting for the lunch. So this is just a picture of a lipoaspirate that is there. So there are four different layers in a lipoaspirate. So the top layer is the collagen or the triglyceride, which is a very thin layer and which might not be appreciated from that much distance. The second layer that is seen is the fat layer or the adipose tissue. The third layer is water and the fourth layer is blood. So depending on how we do the liposuction, there are different techniques like dry technique, wet technique, super wet technique, tumescent technique. What technique we are using, that will lead to the amount of blood loss. So dry technique will have the most amount of blood loss, and the super wet technique and tumescent technique will have the least amount of blood loss. Not going into the details of liposuction. There are different types of liposuction: suction, power assisted, vacuum assisted, laser assisted liposuction, and laser assisted liposuctions. Uh, these are different liposuction cannulas that you saw just now. Moving forward. Just showing some pictures of liposuction. This was called the saddlebags and the outer thighs. This is the some results of liposuction in patients for gynecomastia. You can see the results of just with liposuction. There was no gland excision done in these patients. So these surgeries were performed just with a minimal incision, no scars over the nipple areolar complex or anywhere else. Liposuction for the axillary breast. You can see the results in patients with for axillary breast that is there. In for arm lift, this was liposuction combined with an arm lift. This is not just liposuction. So now coming over to abdominoplasty, or commonly known as tummy tuck. So removal of the excess skin and fat from the middle and lower abdomen in order to tighten the muscles and fascia of the abdominal wall. So goals in abdominoplasty includes optimal resection of abdominal skin and subcutaneous tissue in a three-dimensional manner. And it leads to improvement in abdominal wall contour and reconstruction of a natural appearing umbilicus. So these are the different examples of how fat distribution is there in males and females. Mainly in women, fat deposition is in lower trunk, hips, and posterior thighs. In men, accumulate intra-abdominal fat, increasing overall abdominal girth. So, finally, achieving an optimal outcome in each patient inevitably require individual techniques that are tailored to the patient's anatomy and a thorough understanding of patient goals. Proper patient evaluation, meticulous attention to detail, and flexibility in surgical planning. So when we are doing an abdominoplasty, we are not just going by one approach for each patient. Each patient's approach has to be individualized as per the patient's need. There are different incisions and patterns that are in abdominoplasty that we plan for individual patients. So not going into details of contraindications and all those. Just Now, this is the minimal mini abdominoplasty or the infraumbilical abdominoplasty, which targets the mainly the infraumbilical area. And it is done with a small incision. And ideal candidates for a mini abdominoplasty are patients with adequate distance between the symphysis and the umbilicus. And prior phanelistin incision is also an indication for mini abdominoplasty, and it is often combined with liposuction for blended contouring and contraindicated for patients with upper abdominal rolls or significant upper leg fit. So, what are the other? This is a standard abdominoplasty with a bucket handle shaped incision with a long incision, and this is another extended abdominoplasty with lateral focused skin excision. And this is another example of fluoridils abdominoplasty in which the vertical laxity of the skin is also being addressed. So this is a high definition abdominoplasty, and Panniculectomy is what is being done in massive weight loss patients. Massive weight loss means patient reduces 20 to 25% of the body weight, there will be a loose abdominal panniculus that will be hanging, and in that undersurface of that panniculus there will be fungal infections, superficial bacterial infections, and difficulty in day-to-day activities. So reducing that excessive panniculus helps to patient in day-to-day living. In this case, we do not tighten the muscle and liposuction or moving of umbilicus system. Okay, and what are the reported improvements in patients undergoing abdominoplasty? They report improvements in their back pain. They report improvements in urinary incontinence, irritable bowel syndrome, and they improved sexual function. Complications of abdominoplasty, there are different complications. Overall complication rate is 4%. Hematoma formation is the most common complication, and most of the times it is managed conservatively. No active intervention is needed. Infection rate is 27%, and higher risk factors is male sex. Age is more if age is more than 55, and body mass index is more than 30. Combined procedures increase risk of up to 10.4%. And DVT risk is also present, that is approximately 0.5%. So there are few pre-op and post-op results of abdominoplasty. This is the pre-op and intra-op picture, how we reduce the excess skin fold. Liposuction was also performed in this patient. Another case of lipoabdominoplasty with liposuctions. This is another patient who has undergone a lipoabdominoplasty. Now, circumferential lifts. Circumferential lifts are mainly performed in patients with who has central obesity, loose skin folds in the abdomen as well as at the back, and can improve the lateral thigh also and can tighten the abdominal wall. So there are few pictures of circumferential lifts. Now, coming to medial thigh lift, it improves the contour of the leg. Scars start at the groin crease and goes down medially up to the knee. This is how medial thigh lift is being performed. Another case with medial thigh lift. Mons reduction, it regenerates the pubic area of massive weight loss patients. Upper body lift, it improves contour of the chest or breast and lateral chest fold and upper arm. Includes mastopexy and brachioplasty as well. So, mastopexy, characteristic changes in breast that need to be acted upon are volume deflation, stretching of skin envelope, significant ptosis, flattening of shape, and medialized nipple areola complex. So, breast ptosis had different grades, mild, moderate, and severe. It depends in relation to the inframammary fold and the position of the nipple in respect to the inframammary fold, that is, breast ptosis has to be addressed. So this is the algorithm of how mastopexy or what procedure has to be planned for the patient. I'm not going into the details of those things. Breast augmentation, what options are available for breast ptosis are breast augmentation, breast lift or mastopexy surgery, and breast reduction has to be performed in the gigantomastia or severe huge breasts. So different techniques are described like inverted T-scar, linear scar or vertical scar pattern. These are the different techniques that are being described, vertical or short scar technique, and these are the few results after breast reductions. Going forward, brachioplasty or the inner arm lift that is called as upper improves the contour of the upper arm, and scar placement is the key. Sometimes extends up to the axilla, so to prevent contractures, the scar has to be placed strategically, and it also improves the lateral chest fold. So this is the double ellipse technique, elliptical excision with Z-plasty at the axillary crease to avoid scar contracture across the axilla. And L technique, it represents shape of excision with long limb along medial axis of upper arm and short limb meeting at right angles across axilla along mid-lateral chest, like this. So the final scar will be in a shape of an L. So these are few results of brachioplasty. This I had initially showed you in the liposuction as well. Coming to face and neck lift. In massive weight loss patients, premature aging of face, hollowness, and tend to lose more volume in mid-face. Skin is lax and less elastic. It is technique of lifting up of the soft tissues of the face with repositioning of fat to give a younger look and a more functional face. So these are some results of face and neck lift. So these are the results like abdominoplasty and thigh-plasty, circumferential belt lipectomy, upper body contouring, augmentation and mastopexy, and brachioplasty. So this was a patient who had undergone around bariatric surgery, and in 2 weeks he had around 40 kgs of weight loss, and he underwent a circumferential belt lipectomy with breast reduction. So body contouring surgery is safe for you if body mass index is less than 30, stable weight for 6 months, good nutrition, non-smoker, good general health, and excess skin bothers you more than the scars, and trouble fitting clothes and happy with shape of the body. Finally, optimization of result in body contouring surgery requires simultaneous visualization of all body regions, and factors affecting choice of technique are gender, age, general condition, and patient wishes. Finally, we are limited only by our imagination and not by our skills or resources. So the main takeaways are different bodies require different techniques, can improve confidence, appearance, and health. Safety first, stable and appropriate weight, good nutrition, and staged procedures. Thank you.
Thank you, sir. We'll be having questions during lunch. I request Dr. Nusrat Farooqi sir and Dr. Khayyum Khan sir to kindly felicitate our uh, young surgeon, Dr. Zakir Momin sir. Please.
Thanks, Dr. Zubair, for the kind introduction. Bismillah ar-Rahman ar-Rahim. Obesity, I think being the last speaker, I promise the audience I'll try to cover up the time. I'll be fast and try to cover up for the time lag. Obesity from menarche to menopause. Obesity takes a heavy toll on women's health right from menarche to menopause. Incidence of obesity has tripled in the last 2 decades. WHO has declared obesity as a global epidemic. After the COVID pandemic, I think now the physicians should get up to face the obesity epidemic. Statistics have shown obesity is overtaking tobacco as a leading preventable cause of cancers. We know that obesity is a multifactorial, chronic, progressive, and relapsing endocrine disease which affects the health of the female right from puberty, her reproductive life, pregnancy, and up to menopause. The ectopic body fat acts as an active endocrine organ, producing adipocytokinins and inflammatory mediators that disrupts the metabolism and the endocrine function of the female. Why does early menarche occur? Excess of adipose tissues functions as an endocrine organ. It decreases the levels of SHBG. So there is increased free estrogens and testosterone. There is increase in adipocytes and leptins. And what does this leptins do? They cause the stimulation of pulsatile GnRH. So premature stimulation of pulsatile GnRH leads to premature trigger of HPO axis. So the girl has menarche, early menarche. It's a common scenario nowadays in the clinics that an anxious mother brings her 10-year-old girl. She's worried that none of her friends have attained menarche, but her daughter has. So when you look at the way the girl is obese, and this poor mother, she's just worried for the menarche. She doesn't know what the lifelong sequelae of this early menarche is on her daughter. So what are the sequelae? That girl goes into adult obese. Her lifetime risk of cardiometabolic disease is increased. That girl has an increased hyperandrogenic state, which takes her to PCO, oligomenorrhea, and all those cascades of problems. And the worst is there's increased lifetime risk for estrogen dependent cancers. Again, the pictorial depiction of all the same: adult obesity, diabetes, PCOS, and hormone cancers. Always the patient takes excuse when we counsel the mothers. No, no, it's in our family. So we have to put in the minds of the mothers, it is not that obesity runs in the family, it is that nobody runs in the family. This is our job. Now, what is the link between this patient, this mother who was very anxious for her daughter's marriage because of obesity, is happy that the daughter is married, but her happiness does not long last, does not last long. Why? Because this girl starts facing the problem of infertility. We know that any BMI more than 30 independently increases the time to pregnancy and lowers the monthly conception rate. So, what are the problems of obesity and infertility? First, there are menstrual irregularities, ovulatory dysfunction leading to PCOS, altered ovarian response to medication. Whatever the medications you give, the response is very less. Increased obesity leads to decreased AMH, which decrease the ovum quality. Not only the ovum quality is decreased, endometrial receptivity is affected. So the patient also has, if conceived, she comes with miscarriages. The adipocytes, which act as an endocrine organ and release bioactive molecules, which decrease oocyte differentiation and maturation, and also this bioactive molecules affects at the endometrial levels, decrease implantation and cause early miscarriages. Most of the time, it's common scenario in our clinic that when obese patients come, I don't give any medications, just make a strong counseling to reduce the weight, and the miscarriage rate is decreased and she has a full-term pregnancy. So this is the importance of weight reduction. Again, as we all know, PCOS, and we keep on hearing about PCOS, it can cause irregular menstrual cycles. It leads to male type of hormones in the females, which causes infertility. It causes insulin resistance, leading to high BSL levels. We know that. And it leads to reproductive problems, including irregular menstrual cycles and ovulation. Weight loss and fertility. To have an effect on fertility, at least the patient should be counseled at least to reduce 10% of the weight. And most of the time, when we see a patient roaming to so many infertility centers, and when they come, we counsel them for weight reduction. And when they reduce the weight, she comes with spontaneous pregnancy. So this is the importance of weight loss in pregnancy. So at least 10% of weight loss needed to improve the fertility. Now, there are some patients who just go on crash diets to improve fertility. That is also not needed, because again, crash diets, they disrupt the hormone levels and they cause nutritional deficiency. Instead, what we should focus on the patient, focus on making lifestyle changes, eating a balanced diet, and getting regular exercise. Now, what's the role of bariatric surgery? What is the indication? This should be the last resort in obese patients when all the methods have failed and the patient is young and she wants to conceive. This is the last resort. Then, post-surgical. First, the patient should be counseled that she cannot get pregnant for 12 to 18 months of the bariatric surgery because she has to stabilize the weight. And pregnancy outcomes are good after this bariatric surgery because the weight is less. It significantly improves fertility and reduces the risk of GDM and PIH. Now, do obesity related problems end with conception? No, it's a big no. What happens for obesity in pregnancy? Obesity has become so much common nowadays that it's a new chapter in obstetrics. Any BMI of more than 30 at the first antenatal visit is known as is labeled as obesity in pregnancy. Now, this is the most common medical condition encountered in women of reproductive age group. Maternal obesity is a challenge for obstetrics due to its high prevalence and adverse outcomes not only on the mother but also on the baby. See, these are the normal recommendations for weight gain. An average weight women can gain somewhere between around 12 kgs. But for obese women, we just recommend to gain 5 to 7 kgs and never more than 9 kgs. But the irony is 25 to 40% of women gain more weight than they should during the pregnancy. And nowadays, it's not uncommon for us to see most of the females gaining 20 kg weight in pregnancy, which is disastrous. Why? Every trimester has its own complication because of weight. In first trimester, patient is having more of spontaneous abortions, recurrent abortions, as already told. When they just reduce the weight, this bad obstetric history turns to a good outcome. And there are increased incidence of congenital anomalies. Why congenital? We see the congenital anomalies right from head to toe are increased. Neural tube defects, spina bifida, cardiovascular anomalies, limb anomalies, everything. Now, what happens if the patient first it's difficult to get pregnant? Now, if she conceives, she has a list of problems awaiting her. What are the problems? As already we know, it's gestational diabetes, hypertension, preeclampsia. And women are at risk of miscarriage, as already mentioned, and increased risk of congenital anomalies. This is again to show that GDM, preeclampsia, and venous thromboembolisms are increased. Studies have shown that risk of preeclampsia doubles with 5 to 7 increase in BMI, in the pre-pregnancy BMI. And obese gravidas are at an increased risk of stillbirth. Here, whenever any obese patient comes to the clinic, we have to first counsel that she is at an increased risk of stillbirth. Because most of time when there is stillbirth or intrauterine fetal deaths, it is the patients blaming the obstetrician. They just tell हम तो आए थे आप जब बुलाए, we took all the medications, हमने सब sonography किया, then why this death of the baby? So we should make a point that in the first visit itself, we should counsel because of your weight, you're at an increased risk of stillbirths. Then what are the intrapartum complications? Obese patients are at again increased risk of cesarean deliveries, failed induction of labor, prolonged labor, shoulder dystocia, wound dehiscence, and venous thromboembolism. Studies have shown 5% increase in the risk of cesarean section with each increase of BMI of 1. So this we need to counsel the patient because again they blame the obstetrician for increased cesarean rate. It's not because of the obstetrician, it is because of your body weight that your scissor rate is high, going to be high. Now, why there is prolonged labor, why the scissor rate is high, why the obese patient does not have good uterine contractions. The reason is explained by leptin and cholesterol theory. There are elevated levels of leptin in obese women and elevated cholesterol in obese women. What do? Cholesterol causes disrupted contractility of the uterus. So increased cholesterol, no contractility of the uterus. Increase in leptin levels, again they disrupt the contractility of the uterus. It does not cause cervical ripening. So the cervix doesn't open and patient ends up with cesarean sections. It is not only the obstetrician facing the brunt of the obesity, the anesthesia people also have difficulties. Difficult to place the epidural, difficult multiple punctures in the spinal, GA has its own risk. And anesthesia consult should be done before labor in obese patients. Now, risks associated with cesarean delivery. Again, cesarean is not a piece of cake for the obstetrician in an obese woman. Why? There is longer in the time of incision to delivery time, increased incidence of postpartum hemorrhage, increased DVT, increased incidence of wound infection, and of course, those anesthesia issues. This is again to show that if the bomb has not exploded in the antepartum period, the patient can have the explosion of the bomb in the postpartum period in the form of massive postpartum hemorrhage. If the obstetrician and the patient has escaped postpartum hemorrhage, the patient may end up with venous thromboembolism. And we know that pregnancy itself is a hypercoagulable state. So there are increased chances of thromboembolism. Obesity per se increases the risk of thromboembolism. So when both combined together, the risk of the risk of thromboembolism is more, and this lasts up to the 6 weeks postpartum. So it is not uncommon to find patient coming with breathlessness, massive pulmonary embolism, or late night you have a patient with severe headache not responding to the routine analgesics. It's a massive cardiovascular accident. And obese people, they have less lactations. So what are the fetal complications? It's not only the mothers who suffers because of this obesity, her offspring and fetus also suffers. The baby becomes overweight, may have birth injuries during delivery. The baby may have metabolic syndrome later in life and is more prone to have asthma, autism, developmental delays. And the offspring in the lifelong again becomes obese soon, is more prone for the cardiovascular, neurological, and disorders and metabolic syndrome. Now, the risk of this pregnancy with obesity doesn't end up with, with pregnancy. The female keeps on having the risk throughout her life. What is that? More of metabolic syndrome, type 2 diabetes, gallbladder disease, and more of cancers, estrogen dependent cancers. So at the first preconception, at the first trimester, at the first visit, we need to counsel that patient has to optimize her weight and then conceive, so it is good for her and easy for the obstetrician. And any BMI of more than 30, we need to double the folic acid to decrease the incidence of congenital anomalies. Aspirin prophylaxis may be needed, and already as mentioned with the previous speakers, contraindication for anti-obesity and weight loss drugs, not recommended during pregnancy. So the female's problem just doesn't end up with her pregnancy and postpartum. Now, when she enters the menopause, again, she has a heavy toll to pay. Perimenopause is marked by a hormonal imbalances that can disrupt the appetite regulation and increase the fat storage. So, even in a normal woman, the fat storage is increased. What happens? And this increases much more in the obese women. So, what it's known is the menopausal transition accelerates the loss of lean muscle mass and deposition of much of visceral fat. And obesity makes all this to increase. So, the obese postmenopausal, perimenopausal women is at a very high risk for all these menopausal symptoms like hot flushes, all menstrual disturbances, all are exaggerated. Postmenopausal women demonstrates a hyperandrogenic trait and also much of atherosclerosis. Now, what is the main problem? If a normal weight female comes, we give her the hormone replacement therapy, and that we have to think many times before giving it to the obese women, because again this increases the risk of venous thromboembolism. So nowadays, instead of oral route, we are using estrogen creams, that is non-oral routes, because this non-oral route safely bypass the hepatic first pass metabolism, so less chances of venous thromboembolism. And apart from venous thromboembolism, there is increased risk of cancers in the obese postmenopausal lady. Obesity increases the overall risk of cancers by 20%. The estrogen dependent cancers, which are endometrial, ovarian, breast, and colon, are increased. And the hardest to treat, the three cancers, pancreatic, esophageal, and gallbladder are also increased with the obesity. And kidney, liver, stomach, myelomas, meningiomas, and thyroid cancers are more in obese postmenopausal women. To conclude, addressing obesity requires early diagnosis, personalized lifestyle interventions, consistent clinical management to prevent long-term morbidities, and improve quality of life. The patient should be hammered not to take the support of genetics or not to make an excuse of genetics, because if genetic loads the gun, lifestyle pulls the trigger. Thank you.
Questions will be asked. I request Dr. Hafiz Fatima ma'am and Dr. Bushra Sinu ma'am to kindly join felicitate Dr. Reshma Mata. So with this, we have come to conclude our sessions. For the people sitting here, I would like to request everyone to join us for lunch at the restaurant on the ground floor. It is, and for the offline people, we will be taking attendance, and then we will end the meeting. So you all can proceed for lunch. After lunch, there will be meeting that we will be conducting. So as soon as you get done with the lunch, please come back to the same hall for the meeting. एक मिनट सर, मैं ये अटेंडेंस ले लेता हूँ. सर्टिफिकेट ऑनलाइन ग्रुप में आ जाएंगे. To everyone who has joined, certificates will be provided in e-format, and the credit points will be in your account of MMC within a month. And to remind you, the MMC website has changed to mmc.org, and you'll have to re-log in and register on that website. I have done with the attendance. I request everyone to kindly leave the meeting.